joined so far, ma'am.
We'll wait for 2 to 3 minutes and then start it, okay?
Yeah, sure, ma'am. No
At
problem.
least 20 or 25.
Yeah, that's okay.
So this is the part 2 of respiratory system discussion. So we'll start with the two important main topics, the community-acquired pneumonia and the ventilator-associated pneumonia. So starting with the community-acquired pneumonia. Okay. So my outline of the topic would be the definition of community-acquired pneumonia, the risk factors causing the same, the etiology, pathophysiology or the pathogenesis, the clinical features, diagnosis, the severity assessment, the treatment options, complications, and the guidelines. So coming to the previous year questions, there was only one question which has been asked in the FNB, that is the role of corticosteroids in pneumonia. Now, coming to the definition of the community-acquired pneumonia, it refers to an acute infection of the pulmonary parenchyma, which is acquired outside of a healthcare setting. Coming to some numbers, nearly 21 patients of 21 people with the CAP require ICU admission, and around 26% of people require mechanical ventilation. And coming to the mortality of the severe CAP, it is around 25 to 50%. So what are the risk factors for the community-acquired pneumonia? So children and elderly individuals are more at risk for community-acquired pneumonia than patients with chronic medical conditions like COPD, heart failure, diabetes, stroke, obese patients, and immunocompromised individuals. And then any impaired airway reflexes as in neuromuscular disorders or any neurological disorders like stroke, smoking and alcohol abuse, and any lifestyle issues like prisoners, low income group, and exposure to environmental toxins. Coming to the etiology or the microbiology of the CAP. So it's been divided into typical organisms, atypical organisms, and the viruses. So typical organisms are those which are culturable. For example, the most common being Streptococcus, Haemophilus influenza, Moraxella, Staph aureus, Group A Streptococcus, and Mycobacterium tuberculosis. Atypical organisms are those which are non-culturable, and these include Mycoplasma, Legionella, Chlamydia, and Coxsackie burnetii. Coming to the viruses, the most common being the SARS-2 virus, influenza AB, parainfluenza, rhino, adeno, and respiratory syncytial virus. So actually, the incidence of viral infections are more common than the bacterial infections, and in around 62% cases, no pathogen can be detected. The incidence of pneumococcal pneumonia is decreasing due to widespread immunization. So coming to the pathogenesis of community-acquired pneumonia. So how does this happen? So there are around 5 steps or the 5 pathogenic processes which lead to the community-acquired pneumonia. First is colonization. So whatever the pathogen, whether it could be bacterial or viral, basically they first colonize in the pharynx, and after this, the pathogen enters the lower respiratory tract through the microaspiration of the oropharyngeal secretions. And when this happens, the host defense is triggered, which leads to the release of alveolar macrophages. So if these alveolar macrophages can actually stop the infection, then it is okay. But if the macrophages are unable to control, then the local inflammatory response gets triggered, which leads to the formation of pneumonia. So here what happens, the host defense is overcome by the pathogen's virulence or the high inoculum which is present, or because there is a deficiency of the host defense system. So what are the factors which contribute to the pathogenesis of severe CAP? So it depends first basically on the virulence of the pathogen, the presence of the underlying comorbidities, and the host response to that infection. Coming to the clinical features of community-acquired pneumonia. So it can be divided into pulmonary and systemic features. So pulmonary features includes cough, which could be productive or non-productive, dyspnea, pleuritic chest pain, and on examination, you may find rales, crackles, rhonchi, tachypnea or increased work of breathing, the tactile vocal fremitus, egophony or dullness or percussion. Coming to the systemic features, there could be either fever or hypothermia, weakness, altered mental status, hypotension, and any signs of organ dysfunction. So how do you diagnose? So diagnosis is very important. So it can be diagnosed with either non-invasive methods or invasive methods. Coming to the non-invasive methods, you have the hematological methods, microbiology, and the radiology. So in hematological, the basic tests like CBC, RFTs, LFTs, and the biomarkers. In the microbiology, you send for sputum, nasal swabs, blood cultures, ET aspirates, and newer tests like urinary antigen, serological tests, and molecular diagnostics. Coming to the radiography, you diagnose it either with a chest X-ray, CT scan, or a lung ultrasound. Coming to the invasive modalities like bronchoscopy and lung biopsy in a rare case. So as I told, blood investigations, we do all this serum electrolytes, CBCs, biomarkers, LFTs, and the blood cultures, which are very important. So blood cultures have a low sensitivity but carry a high specificity, and the yield is between 5 to 33%. And IDSA or the ATA guidelines say that the blood cultures has to be obtained only in certain situations. So what are those situations? One is if the patient gets admitted to the ICU, or if there is any cavitatory infiltrates in the chest X-ray or a CT, if patients has leukopenia, active alcohol abuse, chronic liver disease, asplenia, any positive pneumococcal urinary antigen test, and a pleural effusion. So next includes the biomarkers. So there are a lot of biomarkers which can be used in community-acquired pneumonia, but the most common which we use are the procalcitonin and the CRP. The others includes copeptin, pro-ANP, adrenomedulin, cortisol, and D-dimers. And these are the various triggers which may lead to the production of all these biomarkers. So small note on about procalcitonin. As we know, the normal values of procal are less than 0.1 microgram per liter. So if a patient presents with a community-acquired pneumonia and his procal values are less than 0.05, then there is a probability of any viral infection. This is not the diagnostic, this one. There could be a probability, that's it. So if the values are around 0.25, there is a probability of atypical bacterial infection. If it is between 0.5 to 0.75, there's a probability of typical bacterial infections. And if the patient has a risk of bacteremia, sepsis, and septic shock, the procal will be usually more than 10. So what are the uses of procalcitonin in the diagnosis or in community-acquired pneumonia? Basically, it helps in differentiating community-acquired pneumonia from any other non-infectious causes. It helps in the de-escalation of the antibiotics and also helps in the severity assessment of the disease. So procalcitonin and CRP measurements need not be performed as a routine investigations for the diagnosis of the community-acquired pneumonia. This is what the guidelines tells. I will discuss about it later. Now coming to the newer tests, as I told, urinary antigen tests, these are required for the diagnosis of Streptococcus and Legionella. The thing is, it has a high specificity of around 95%, and the results are very early, that is less than 15 minutes, and it doesn't have any effect on prior antibiotic exposure. So if you have given an antibiotic, in the next few hours, you can perform this test. The other tests would include serological tests, especially for chlamydia and the mycoplasma. And we all are sending basically this pneumonia panel and all, which is nothing but the molecular diagnostics, which is most sensitive. But the limitations are we will not be able to get the resistance pattern, and they are usually costly. Next, coming to the sputum cultures, gram staining, and in patients who are not able to expectorate, we can do bronchoscopy. So coming to the radiological examination, the important one is the chest X-ray. So basically, what do you find in community-acquired pneumonia? You can find either the consolidation, so you can find any interstitial infiltrates or any cavitatory lesions. Coming to the CT thorax. So do we need to do CT thorax for all the patients who have community-acquired pneumonia? No. There are certain indications for the same. So what are those indications? One is any severe or complex pneumonias in immunocompromised patients, patients who are non-responders of the pneumonia or non-resolving pneumonia is present, or if there is a high clinical suspicion with a normal chest X-ray, especially in neutropenic patients, and there is an alternative diagnosis, you are suspecting a malignancy. To rule out the same, you're going to do a CT thorax. So basically, in cases like complex pneumonias like empyema, or to rule out PCP pneumonia in immunocompromised patients, the CT thorax can be done. Now coming to the lung ultrasound, I think yesterday Dr. Darshan has discussed about this in detail. So lung ultrasound in community acquired pneumonia, it has 60 to 90% sensitivity and greater than 90% specificity. So what are the advantages of lung ultrasound? So it is bedside, radiation free, and it is quick results are available. And it can be even done in a pregnant woman who can't be exposed to a lot of radiation, and it helps in dynamic evaluation of the disease. So appearance, as you know, one is the serrated margins with hepatization. So this is a liver, this is lung becoming like a liver, that is hepatization of the lung. And the second one is you can see the dynamic air bronchograms and a pleural shred sign. So coming to the differential diagnosis of community acquired pneumonia. So differential diagnosis can be divided into two. One is abnormal chest X-ray, and what could be the differentials? So it could be a congestive cardiac failure, aspiration pneumonitis, pulmonary infarction, any acute exacerbation of bronchiectasis, hypersensitivity pneumonitis, or pulmonary vasculitis. If the patient has a normal chest X-ray, then what could be the differentials? One is the acute exacerbation of COPD, or asthma with viral syndrome, any influenza, acute bronchitis, or the pertussis. The important thing in CAP is about the severity assessment, which can be asked as a question for you people. So how could you assess the severity assessment of CAP? So it can be done by four things. One is the IDSA or ATS 2019 criteria. The second one is the pneumonia severity index. The third is the curve 65, and the fourth is the SMART COP. So coming to the IDSA or the ATS 2019 criteria. So these criteria define severe pneumonia as if there is a presence of either one major criteria or 3+ minor criteria. So what are the major criteria? So there should be either a septic shock with a need for vasopressus, or if there is a respiratory failure requiring mechanical ventilation. So if any one of these is present, then it is severe pneumonia. Or any three of the minor criteria, like respiratory rate of more than 30 breaths per minute, PF ratios of less than or equal to 250. If there are multilobar infiltrates in the chest X-ray or in the chest X-ray, any confusion or disorientation, Bunn values of greater than or equal to 20, leukopenia, thrombocytopenia, hypothermia, or hypotension. Now, curve 65, this has been usually asked. So, curve 65, sorry. So C stands for confusion of any new onset, especially there is an altered mental status of less than, or the GCS is less than or equal to 8. U stands for urea of more than or equal to 7 millimoles per liter. R for respiratory rate of more than 30. Blood pressure, that is B, less than 90 mmHg systolic or less than 60 diastolic. And 65 is the age, which is more or equal of the 65 years. So how do you assess the severity? So score 0 to 1 has low severity, and the mortality, 30-day mortality is less than 3%. Coming to if the score is 2, then it is moderate severity, and the mortality here is around 9%. And 3 to 5 is a high severity, the mortality is 15 to 40%. So if the patient has low severity, you can manage in the community. If it is moderate severity, consider in-hospital admission. And if it is 3 to 5, better to admit the patient either in high dependency or intensive care unit. Coming to PSI, the pneumonia severity index, basically it is very difficult to calculate and even remember. Just it has a lot of demographic factors like age, any coexisting illness, physical examination, and laboratory with radiological examination. And the risk classes are divided as 1 to 5. Now, the other important one is the SMART cough. This is a little easy to remember. So the S stands for systolic blood pressure of less than 90. M stands for multilobar chest X-ray involvement. A stands for albumin of less than 35 gram per DL. R for respiratory rate of more than 30. And T for tachycardia. So each of these component carries 1 mark. Coming to the COP, the confusion, which is new onset, carries 1 mark, whereas the oxygen saturation and the pH of less than 35 each carries 2 points. So if the patient, so it is divided into 4 categories. So if the patient has 0 to 2 points, there is low risk of needing IRVS. So what is IRVS? It is intensive respiratory and vasopressor support. So 5 to 6 points has a high risk of needing IRVS, and 7+ is very high risk for needing the IRVS. So this is how you assess the severity of the community acquired pneumonia. Now coming to the main component, the treatment. So what are the treatment goals in the community acquired pneumonia? The first important thing is, or the primary goal is the eradication of the pathogen. The other thing, you have to relieve the symptoms of the patients. And third one, you have to prevent the complications. So the treatment options include the antibiotics, which are the cornerstone of treatment. And some non-pharmacological treatment includes oxygen therapy, hydration, and chest physiotherapy. And the supportive care includes the fluid and electrolyte management and pain control. Now, this is a slide just telling about community-acquired pneumonia algorithm for outpatient treatment. So, just for a overview of this. So, if the patient has no comorbidities, you can either give doxy or amoxicillin or a macrolide. But if the patient has comorbidities like any underlying heart, lung, liver, or kidney disease, diabetes, alcoholism, or malignancy, you have to give either amoxicillin with clavulanic acid or a cephalosporin with a macrolide or a doxy, or you can give a respiratory fluoroquinolone. Important for us is the community-acquired pneumonia algorithm in inpatient patients, especially in the HDU and the ICU. So basically, this is divided into non-severe and severe CAP. So non-severe CAP is basically there is no organ dysfunction. Severe CAP is there is any one or two organ dysfunctions which are present. So in non-severe CAP, first we have to see whether the patient has a risk factors for any MRSA or a Pseudomonas aeruginosa. If there is no risk factor, you can give a respiratory fluoroquinolone. Then in a non-severe, you have to see whether MRSA risk factor is present. Okay, it is non-severe plus a risk factor for MRSA is present. Then what you have to do is you have to obtain the cultures or a nasal PCR, and you need not to start empirically an anti-MRSA therapy. You can wait if it is non-severe. Second, same, if it is non-severe and there is a Pseudomonas aeruginosa risk factor, you have to obtain cultures and you need not to start the empirical anti-Pseudomonal therapy. But the opposite is with the severe. So if there is no MRSA or there is no Pseudomonas aeruginosa risk factor, you have to give a beta-lactam plus a macrolide or a fluoroquinolone. If there is an MRSA risk factor, you have to send the cultures and empirically start the MRSA therapy. Same severe plus a Pseudomonas risk factor is present, you have to start the empirical treatment for the Pseudomonas aeruginosa. So what are the drugs? So anti-pseudomonal antibiotics, what are those? So these include ceftazidime, cefepime, cefaperazone, piptas and penoms like meropenem, mepipenem, and fluoroquinolones. MRSA cover include vancomycin, teicoplanin, linezolid, and tigecycline. And to have a small thing, linezolid is basically used for vancomycin intolerant patients and vancomycin resistant Staph aureus, and also in patients with renal failure because vanco can't be given at this situation. Now, this is the empirical treatment for in-hospital therapy of community-acquired pneumonia. As I told, moderately severe CAP is no acute organ dysfunction, and severe CAP is there is an acute organ dysfunction. So the primary treatment for moderately severe is any beta-lactam antibiotics. So we either give ceftriaxone or cefuroxime, and the alternative therapy could be either a fluoroquinolone, like a moxiflox or a levoflox. So if it is a severe CAP, we usually start with piptas, and then go for meropenem depending upon the clinical situation, and the alternative therapies are the same. Now coming to the duration of antibiotics for community-acquired pneumonia. So if it is a non-complicated community-acquired pneumonia, you can give the treatment for 7 to 10 days. But if the CAP is due to Pseudomonas or aspiration pneumonia, you have to continue the antibiotic for 14 days. If it is a necrotizing pneumonia due to any GNB, MRSA, or anaerobes, the treatment should be extended to 14 to 21 days. Okay, and the duration of treatment basically should be individualized according to the causative organism, the response, the severity of the disease, and complications. So serial PCT levels can be used for de-escalation of the antibiotics along with the clinical judgment in patients who are treated beyond 5 to 7 days. So just a word about the newer antibiotics. I'm not going in detail of this. So these are just the names. So ceftriaxone, erythromycin, solithromycin, leflunomide, omadacycline, and dilafloxacin. So I think you have to go through this just as a short note. Now coming to the adjuvant therapy, the important thing is the corticosteroids. So coming to corticosteroids, you have the IDSA or ATS 2019 guidelines. What does they tell about the corticosteroids in CAP? So they tell that we recommend not routinely using corticosteroid in adults with non-severe CAP. So it has a strong recommendation. So if the patient has a non-severe CAP, there is no routine use of corticosteroids. But if the patient has severe CAP, okay, we suggest not routinely using corticosteroid in adult with severe CAP, but it is a conditional recommendation. Okay, and they tell that we endorse the SEC recommendations on the use of corticosteroids in patients with CAP and if there is a refractory septic shock. So this is the IDSA guidelines. But what are the ESICM 2023 guidelines which have come recently? They suggest that in patients with severe CAP, we suggest use of corticosteroids if the shock is present, and this is a conditional recommendation with a low quality of evidence. So at the same time, we had a trial, that is the Cape Cod trial, which has been come in NEGM journal in 2023. So hydrocortisone and severe community acquired pneumonia. So what was the clinical question here? So in patients with severe CAP, does the use of hydrocort compared to a placebo reduce the 28-day mortality? And what they concluded at yes, it reduces the 28-day mortality. Now coming to the primary and the secondary outcomes of the study, if you see, the primary outcome was death by 28-day. Okay, so hydrocortisone group had 25 deaths, whereas the placebo group has 47 deaths. So the p-value is very significant. So it has some mortality benefit. But the thing is, the median daily dose of insulin is been increased in hydrocort because steroid-induced hyperglycemia. So coming to the other one, the low molecular weight heparin. So what happens in CAP is there is an activation of coagulation system, which appears to be a major pathophysiological event in severe pneumonia. Hence, all the patients with severe pneumonia has to undergo prophylaxis for thromboembolism. So coming to the complications of community-acquired pneumonia, there could be respiratory failure, shock with multi-organ failure, coagulopathy, lung abscess, and complicated pleural effusion. So this is just a slide to tell you the difference between the 2007 IDSA guidelines and 2019 IDSA guidelines. So you can go through it later. And these are the recent 2023 ERS or ESCCM guidelines. We have already shared the PDF with you. So basically everything is very low or low evidence quality. So nothing much other than we know in the things which we are doing. So thank you. Okay, now the next topic, the ventilator-associated pneumonia. So the outline of this topic would be the definitions, the risk factors, what are the pathophysiology, classification, diagnosis, treatment, and the prevention. So what are your previous exam questions were? Diagnosis and management of VAP, it was in FNB. And in recent DRNB 2022, they've asked about the definition of ventilator-associated events and VAP for 6 marks, and preventive strategies for VAP 4 marks. Okay, so important, the next 3 slides are only of definitions. So easy way to remember, and they are very important also. So now, if you see, there are 2 things here. One is in hospital under 48 hours, in hospital over 48 hours. Okay, so in hospital under 48 hours, you have to see all these things. What is this? Whether the patient has been hospitalized in an acute care hospital for 2+ days within the past 90 days. Okay, whether they have resided in a nursing home or a long-term facility within the 90 days, whether patient received any home infusion therapy in the past 30 days, or received chronic dialysis within the past 30 days, and or any family member has been exposed to the MDR organisms within the 30 days. If none of these is present, then it is CAP. If any of these is present, then it is healthcare associated pneumonia. And The second part is if the patient is in the hospital over 48 hours. And you have to see whether the patient is ventilated or not ventilated for more than 48 hours. Okay, if the patient is not ventilated for 48 hours, then it is hospital acquired pneumonia. And if it is ventilated for more than 48 hours, then it is VAP. Now, this is the one. So, ventilator associated event. So, initially, we would only define it as ventilator associated pneumonia. But what happens is the VAP rates as a quality indicator has generated debate due to lack of gold standard definition. Hence, in 2013, the CTC has replaced the surveillance definition from VAP to VAE. So, ventilator associated events have four things. One is the VAC, ventilator associated condition. The other one is IVAC plus, that is infection related ventilator associated complication plus. The other is plain IVAC and PVAC. Okay, so what is ventilatory associated condition? So any patient with a baseline period of stability, or if they show any improvement for more than 2 days, but there is an increase in the FiO2 requirements and the PEEP of greater than 3 centimeters of water for greater than 2 days, then it is known as ventilator associated condition. So what is IVAC plus? It includes the ventilator associated condition plus if you have a suspicion of infection and you have started any new antibiotic for the present condition. So that is IVAC plus. So what is IVAC? It is basically the IVAC plus, and if you have done cultures, there is no respiratory pathogen, that is minus, no respiratory pathogen. If there is a respiratory pathogen confirmed, then that is possible VAP. Okay, this is very important. This have been asked recently in your exam. So you need to write this one. Now, also you should know about what is MDR, XDR and the PDR organisms. So as you know, not MDR means basically the organism is not susceptible to greater than or equal to one agent in less than 2 antimicrobial categories. But MDR is if the pathogen is resistant to one agent in 3 or more than 3 antimicrobial groups. Like if the organism is resistant to ceftriaxone, that is cephalosporins, bacterium, and the ciprofloxacin. Okay. Then what is XDR? If the organism is resistant to one agent in all, but only sensitive in 2 antimicrobial groups. Like it is only sensitive to tigecycline or colistin, then it is XDR. What is PDR? Pan-resistant, which is resistant to all antimicrobial agents. Okay, so these are the definitions. Now coming to the risk factors for VAP. So you have to write in a subheading. So one is the mechanical factors, which includes emergency intubation or re-intubation, increased duration of intubation. If you take a lot of increased chances or number of persons also, if it is increased, then the risk of VAP is more. Supine positioning, use of paralytic agents, and underinflation of the ET cuff. The second one is the mental status. So any decreased mental status like CNS disease, low level of consciousness, or increased level of sedation, that is one of the cause for the VAP. Next, bacterial bioburden in the upper respiratory as well as in the orogastric tracts. Especially the duration of the hospitalization matters, nasogastric intubation, prolonged antibiotic exposures, or use of PPIs or other gastric acid suppressants. Coming to the patient factors, age more than 70 years, any pre-existing lung disease, the severity of the illness, or any surgical burns or trauma patients are at risk of VAP. And others includes like ICU understaffing or transportation of out of ICU for any diagnostic image or procedures. Now, also you have to know about the risk factors for MDR pathogens in VAP. So what are those risk factors? If age is more than 60 years, the duration of mechanical ventilation is more than 7 days, prior antibiotic use within 3 months, presence of septic shock at the time of diagnosis of VAP, ARDS preceding VAP and RRT preceding VAP, and any systemic corticosteroid therapy. So if these risk factors are present, then you have to add a, you have to think of MDR pathogen and escalate your antibiotics accordingly. Now coming to the pathophysiology. So this is easy way which you can remember. So what happens if the endotracheal tube in place? Okay. So what happens is this endotracheal tube causes significant impairment of the mucociliary clearance of secretions because the natural barrier is gone. Also, because of the same, it subverts patient's natural mechanisms for preventing access to microorganisms to the lower respiratory tract. Also, there is a formation of bacterial biofilm upon the ETT polymer, and there is a microaspiration and leakage of oropharyngeal secretions around the inflated ETT cuff. All this leads to the VAP, and additionally, the positive pressure ventilation which we give plus the gravity effect leads to movement of secretions and microorganisms into distal respiratory tract. And if additionally in a critically ill patient, there is impaired innate and adaptive immunity, which leads to VAP. Now coming to the classification, traditionally the VAP was classified as early onset VAP and late onset VAP, where the early onset VAP was first 4 days and late was after 4 days. And in early onset has a sensitive organisms, late onset MDR pathology, and it was associated with high morbidity and mortality. But now almost all the cases of VAP are caused by MDR organisms. This classification of early and late onset VAP has been removed. Now coming to the diagnosis. So first one is the modified CDC criteria, which says that either chest X-ray, there should be chest X-ray opacities like any new progressive or persistent infiltrates or any cavitary lesions with at least 2 of the following. Like there could be fever, leukocytosis or leukopenia, altered mental status, new onset of purulent secretions or worsening gas exchange, and bronchial breath sound. So any of the 2 with the chest radiograph features, then there is and you can diagnose VAP on the basis of this modified CDC criteria. The one which we regularly use is the clinical pulmonary infection score. So there are 6 points here. One is the tracheal secretions, chest X-ray infiltrates, temperature, leukocyte counts, PF ratios, and microbiology. And it has been graded as 0, 1, 2. So score of greater than 6 has a good correlation with VAP, whereas less than or equal to 6 has a good prediction to discontinue antibiotic therapy after 3 days. So coming to the guidelines, the IDSA 2016 guidelines are for the VAP. So what does those guidelines tell about the VAP? So you have to take a non-invasive sampling with a semi-quantitative cultures to diagnose the VAP rather than going into an invasive or a quantitative cultures. So what is invasive respiratory sampling? So any bronchoscopic techniques like BAL or protected specimen brush or a blind bronchial sampling, that is mini BAL. And what is the non-invasive is the endotracheal aspirator. Now second, if some clinicians feel that you have to perform the invasive quantitative cultures, then what is the threshold at which you can stop the antibiotics? So if you have done a bronchoscopic or a mini-BAL cultures, then less than 10 to the power of 3 colony forming units, you can de-escalate the antibiotics. And if you're doing a protected specimen brush, it is less than 10 to the power of 2 colony forming units per ml. Now coming to, they tell that they recommend using clinical criteria alone rather than using the serum PCT or rather than using the BAL TREM1 plus. So these in some institutions are using it. So they've actually done a lot of studies which showed that the clinical criteria alone is enough for the diagnosis of VAP. So it has a strong recommendation and moderate quality evidence. Same recommended clinical criteria rather than using CRP plus clinical criteria or rather than using SIPS criteria along with clinical criteria. So coming to the treatment. So you thought of having VAP, and then you have to see for 3 important things. What is the prevalence in your institute of MDR pathogens, prevalence of MRSA, and the prevalence of resistant gram-negative organisms. So if you see, first we'll discuss about this black arrows. So if there is a low risk of MDR pathogens and there is a low prevalence of MRA, that is less than 15%, And there is a low prevalence of resistant gram-negative organisms, which is less than 10%. So you can use a single antibiotic which is active against both MSSA and the Pseudomonas. Okay, but next we'll go to the green arrows. So if there is a high risk, there is a low risk of MDR pathogens, and there is a low risk of MRSA. Okay, but there is a high prevalence of gram-negative organisms. Then you have to use two agents which are active against gram-negative organisms, including the Pseudomonas. Okay, the other one is everything is high. The MRSA prevalence is high, the MDR pathogens is high, and gram-negative organisms is high. In such a case, you have to add an agent which is active against MRSA and at least two agents which is active against gram-negative, including Pseudomonas. Now, so commonly used antimicrobial agents are, we start usually with piptaz or meropenem, depending upon the clinical condition of the patient. And the studies have shown that carbapenems have a higher chance of clinical cure than the non-carbapenems. Now, coming to the high risk cases of Pseudomonas, what are the risk factors for Pseudomonal infections, especially in the VAP? So, if there is any prior Pseudomonal colonization, if the hospital duration of hospital stay is more than 48 hours before the ICU admission, any underlying COPD, mechanical ventilation duration more than 8 days, more than 3 previous hospitalization, and prior use of antibiotics. All these are the risk factors for Pseudomonas, for which you need to add a anti-Pseudomonal agents. So what are those? We have discussed already in the CAP PPT. So coming to anaerobic cover in VAP. So basically it is not routinely used. It is only used only if there is a presence of risk factors like altered consciousness, aspiration pneumonitis, and high SAP score. So the drugs used are clindamycin and metronidazole. Coming to the atypical cover. So the incidence of atypical cover in VAP is 5 to 7.5%. So empirically, you need not to start only if there is a risk factor that is present, like Legionella colonization in the hospital water supply, prolonged use of corticosteroids or cytotoxic chemotherapy, elderly, patients undergoing dialysis, or granulocytopenia or poor GCS. So the drugs used are either fluoroquinolones or the macrolides. Now, what does the guidelines tell about the treatment of VAP? So they tell that you have to include coverage for Staph aureus and Pseudomonas aeruginosa and other gram-negative bacilli in all empirical regimen, which is a strong recommendation and low quality evidence. And if there is an MRSA, if you need a cover, so they either recommend vancomycin or linezolid, which is also a strong recommendation. This is not so important. Now, coming to prescribing true anti-Pseudomonal antibiotics from different classes for empirical treatment of suspected VAP if the risk factors for Pseudomonas is present. Okay. And if there are no risk factors for Pseudomonas, then you can actually give a single antibiotic. So they also tell that avoid using cholesterol if any alternative agents with adequate gram-negative activity are available. So this is the one which they have given. So these are the gram-positive antibiotics with MRSA activity, which we use in VAP. One is glycopeptides, that is vancomycin, or oxazolidiones like linezolid. Gram-negative antibiotics with anti-Pseudomonal activity, which are beta-lactam based. So those are piptaz or cephalosporins, carbapenems, and the monobactams like aztreonam, and non-beta-lactam based agents like fluoroquinolones, aminoglycolates, or polymyxins. So few things which we have to remember is, so as our country has a high endemicity for tuberculosis, the use of linezolid may be restricted unless no suitable alternatives is available. So for treatment of VAP due to MRSA, glycopeptides and linezolid has similar clinical success. However, linezolid may be associated with higher chances of thrombocytopenia and GI adverse effects. And fluoroquinolones and aminoglycosides should be cautiously used as monotherapy in VAP. So what is the duration of antibiotic treatment in VAP? So if there is a good clinical response, then a short course of 7 to 8 days is enough. But a longer duration of 14 days is required if the VAP is caused by non-fermenting GNB, if there is severe immunodeficiency, any underlying structural lung disease, if there is an empyema or lung abscess, necrotizing pneumonia, and inappropriate initial antimicrobial therapy. So when to de-escalate? So how to de-escalate? And so PCT may be used in such cases to de-escalate of antibiotics when the duration is more than 7 to 8 days. And for this, serum PCT levels together with clinical response should be used for de-escalation in specific clinical conditions like immunocompromised patient, drug-resistant pathogens, or non-fermenting GNB. Now, coming to role of inhaled antibiotics in VAP. So they tell that for any VAP patients with a gram-negative bacilli, which are susceptible to only aminoglycosides or polymyxins, so we suggest both inhaled and systemic antibiotics rather than systemic antibiotics alone, but this has a weak recommendation. Okay, so they tell that it is reasonable to consider adjunct inhaled antibiotic therapy as a last resort for patients who are not responding to IV antibiotics, whether the infecting organism is a multi MDR or a non-MDR also. So this is the last slide about approach to a patients of non-responding VAP. So what is non-responding VAP or treatment failure in VAP? It is defined as a lack of improvement in the clinical parameters with or without persistence of infecting microorganisms from appropriate samples. So what could be the causes? It could be due to wrong diagnosis or any inappropriate initial therapy, delayed initiation of treatment, if there is a super infection, or a concomitant focus of infection in any other area, or associated complications like the pneumonia going into lung abscess, empyema, or any drug fever, advanced stage immunosuppression, chronic lung disease, and drug-resistant pathogens. So in such cases, we need to reevaluate the patient 48 to 72 hours after initial diagnosis. And last one is about the prevention of VAP, that is a VAP bundle. Actually, there is a lot of confusion going on with this VAP bundle. So so the recent one is by in 2016, which was given by the Intensive Care Society. So initially in December 2004, it included 4 components. One is head and elevation to 30 to 45 degree, daily sedation vacation, peptic ulcer prophylaxis, and DVT prophylaxis. Okay, in 2010, the IHI actually added one more component, that is the daily oral care with chlorhexidine. Now, this has been modified in 2016. So, what are those? Presently, the same head and elevation is the same, daily sedation vacation is there, but use of subglottic secretion drainage is the additional one, avoidance of scheduled ventilator circuit changes, oral hygiene without chlorhexidine, and PUD prophylaxis only in high risk patients. So this is the one which I got it, and this was given by the Intensive Care Society in 2016. So these are my references. Thank you. So any questions, please put it in the chat box. We'll try to answer it.
Okay. Thank you, ma'am. There was one query by one of the candidates. So they had asked on risk factors for Pseudomonas cap and MRSA cap, and I had responded it to it. So I think other than that, there were no new other questions that had come up.
Okay.
To the candidates, both CAP and WAP are both very important from a theoretical perspective and more important from a practical perspective. You can expect a lot of questions from both of these topics. So it is very, very important to know about it. And I think Madam has covered it in depth and has needed for your theory exams also. So, ma'am, anything else that you would like to add on for the candidates before we move on to the next topic?
Nothing, Srihari. You can carry on.
There are, sorry to disturb,
Okay.
there are a few scoring systems where we talk about risk factors for streptococcus, pneumonia, MRSA, and other things. Like when we think about these occurrences in the regular patients who walk into the ICU, the scoring systems help us, understand that these people are at a higher risk. So for MRSA, I think so. Madam has already presented in the talk. So if patients walk into the ICU with, post-dialysis status, immunocompromised status, or on any other type of uncontrolled diabetes, there are scoring systems which are available. I cannot recollect the name, but I will just definitely put it in the chat box. So it's used in a few settings, but cannot be generalized to all. That's about MRSA. Pseudomonas, there is no specific scoring system that can be utilized. Okay, thank you.
And also another, just an important add-on, Madam had mentioned about IDSA and PSA. The importance of these two scoring systems are, these two are alone validated scores. There is another CAP-PYRO score, which has also been mentioned, but it is an important score, but it has not been validated for the diagnosis and for the prognostication of VAP. So that was an extra add-on to the topics that Madam had discussed.
Okay, the score's name is actually called as the Shore score. You can get it on MDCal and other things. You can just type that score and you can use that. I'm sorry, that is the score which we usually use for MRSA risk factors. So there are 5 to 6 risk factors in that. It's still not widely validated. It is very specific to a few conditions alone, especially for pneumonia settings, MRSA only. You cannot use it for other infections like UTI or an abdominal sepsis, so on. The spelling is SHORR. Okay, I'll just type it in the chat box. Okay.
And also, in relation to VAP that ma'am had mentioned, thing is the definitions, the surveillance definitions in relation to VAP, that is that ventilator-associated events, infection-related ventilator-associated events, and VAP. These 3 definitions are very, very commonly asked in practicals. So in theory also, in quite a few question papers, they have asked these definitions, but in practicals, invariably, if you get a patient on mechanical ventilation for a long duration, like neuro or neurosurgery patients, you are high likely to anticipate these questions. So it is very, very essential to know about these definitions also. Okay, so then shall I move on to my topic, madam?
Yeah, Srihar. Yeah, Srihar. Carry on.
Okay, I'll start mine then.
Yeah.
Is my presentation visible?
Yeah, you can put it in a slideshow mode.
Is it okay?
Yeah.
Fine, okay. So my first topic for this evening is on weaning from mechanical ventilation and weaning failure. Okay. So whether questions have been asked in relation to this, yes, they have been asked, and more importantly, they have been asked in relation to weaning failure or difficult weaning. They have been asked in FNB and in DM exams. Most importantly, in SGPGA exams, there were questions in relation to this. More importantly, from a theoretical perspective, from practicals, it is very, very important because difficult weaning is usually kept as a short case also. And it is also important from clinical practice perspective also. So from all these point of view, it is important that you know about it. So my topics for discussion will be on the introduction, the definition, the classification of the weaning process, the readiness testing, SBTs, and extubation. So this will be in relation to weaning from mechanical ventilation. So coming to the introduction, weaning from mechanical ventilation is an essential and a universal element in the care of a critically ill intubated patient receiving mechanical ventilation. I think this is something which all of you will know. So liberation from mechanical ventilation is a 3-step process. So it involves readiness testing, weaning, and extubation. So usually when a patient gets intubated and mechanically ventilated, this is usually the course that usually happens in most of the patients. Usually there will be treatment of acute respiratory failure. Example, if there is a pneumonia, which madam had spoken about, they would be initiated on antibiotics. Then once the patient's condition starts to improve, then we suspect whether the patient is okay for a weaning trial. Then we assess the readiness to wean. Then we perform a spontaneous breathing trial. And if they satisfy the criteria for it, then we go ahead extubation. And if there is no issues post extubation, that is the patient is neurologically, hemodynamically, and from a respiratory perspective is doing well, then we avoid intubation. But if any one of the 3 issues does occur, then we have to decide on reintubation. And based on whether reintubation is needed or not, the discharge time will vary. So coming to the definitions of all those that I just spoken in the previous slides, treatment of ARF is the period of care and resolution of the disorder that caused respiratory failure and prompted mechanical ventilation. This is very much self-explanatory. Then suspicion is the point at which clinician suspects the patient may be ready to begin the weaning process. Then assessing the readiness to wean is the daily testing of physiological measures of readiness for weaning. That's the example, maximum inspiratory pressures, then the RSBA, etc., to determine the probability of weaning success. Then performing the SBT, that is assessment of the patient's ability to breathe spontaneously. And then the next thing is about extubation, that is removal of the endotracheal tube. And reintubation is replacement of the endotracheal tube for patients who are unable to sustain spontaneous ventilation. So these definitions per se are not much important from a theoretical perspective, but very, very important from practical exam perspective. It is very high likely to be asked. So classification of the weaning process can be classified into three parts. One is simple weaning. Now, simple weaning can be defined as patients who proceed from initiation of weaning to successful extubation on the first attempt. It's very important. On the first attempt without any difficulty. This is most likely in patients who come from the operation theater who have just been kept for overnight observation and next day they're usually extubated. Difficult weaning are patients who fail initial weaning and require up to 3 SBTs. I repeat, they require up to 3 SBTs or as long as 7 days from the first SBT to achieve successful weaning. And prolonged weaning are patients who fail at least 3 weaning attempts or require more than 7 days of weaning after the first SBT. So these are the 3 definitions that have been provided by the ERS. All right, simple, difficult, and prolonged. So it is very important to remember these definitions. So now next coming to the readiness testing. So the definition of it is, it uses objective clinical criteria and occasionally physiological criteria to determine whether a patient is ready to begin weaning from mechanical ventilation. So the main goal is readiness testing identifies patients who are ready to wean as well as those who are not ready to wean from mechanical ventilation. So how does this benefit us? So if you are able to identify those who are ready to wean, it avoids unnecessary complications of ventilation like ventilator-induced lung injury and etc. And those who are not ready to wean, you don't have to proceed with SBT because it protects the patients from risks of premature weaning like cardiovascular dysfunction, respiratory muscle fatigue, or psychological distress. So that may further impair the subsequent weaning trials also. So the important things that have to be taken into consideration for assessing readiness to wean are, first is clinical and you have objective. So in clinical, you have to assess for adequate cough, absence of excessive tracheobronchial secretions, resolution of disease, acute phase for which the patient was intubated. Like example, a patient had come with a community-acquired pneumonia with a PF less than 200 with severe tachypnea. You intubated the patient. You had initiated on antibiotics. Over the course, the patient had improved. And then now we are planning for weaning. So that is resolution of the disease process for which the patient was intubated. So coming to the objective parameters that you have to look into, the first thing is you have to look into the clinical stability. So you have to assess the cardiovascular status. The important thing is the heart rate should be less than 140. The systolic BP should be between the range of 90 to 160 with either no or minimal vasopressors. The important thing I want to emphasize is if the patient is on low dose noradrenaline infusion, it does not mean that they are not fit for weaning. You can proceed for weaning in those patients also. And the patient has a stable metabolic status. That is, the lactates are normal, the peripheral perfusion is good, mentation is good. The next is to assess for adequate pulmonary function. That is, the respiratory rate should be less than 35 breaths per minute. The maximum inspiratory pressure should be in the negative range. That is less than 20 to less than 25 centimeters of water. Tidal volume of more than 5 ml per kg. Vital capacity of more than 10 ml per kg. And RSBA, rapid shallow breathing index, less than 105 breaths per minute per liter. And there should not be any significant respiratory acidosis. Now, there has not been any specifically mentioned pH because there may be patients with chronic respiratory failure who might have present with an acute condition. So in those scenarios, it is difficult to mention the exact pH value. But usually in most scenarios and most articles, they do mention that a pH more than 7.3 should be an ideal indication to proceed for weaning. And next is about adequate mentation. The patient should not be on sedation or should have an adequate mentation on sedation. That is, a RAS score of 0 to -1 would be adequate. And the patient should have a stable neurological status. And adequate oxygenation should be there. That's the saturation should be more than 90% with an FiO2 of 40% or less and a PF ratio of more than 150. And PEEP should be less than equal to 8 centimeters of water. But the important thing is 30% of patients who do not satisfy such criteria may be being successfully. So it doesn't mean that you should not know about it. You should know, but there may be some patients who actually you feel that they may actually be like, how do you say? Even though they do not satisfy the objective criteria, there may be some patients who actually, once you extubate, are stable without the need for reintubation. But experience plays an important role in that. So next thing is we have integrated weaning indices. The most common and the most well-known is the rapid shallow breathing index. That is the respiratory rate by tidal volume, the tidal volume in liters. And the value should be less than 105 breaths per minute, which is associated with successful weaning. Then we have the crop index that includes the compliance, the respiratory rate, the oxygenation, and the pressures. And the score should be more than 13 to be associated with successful weaning. Then you have another one called the core index, which includes the compliance, oxygenation, the respiration, and the effort. And in this, the score more than 8 is associated with successful weaning. And you have something called the integrative weaning index. So in comparison to the top 3, this is supposed to be more accurate than the other predictors, but performing this static compliance testing is supposed to be difficult in a spontaneous breathing patient. So that is a very big pitfall to this. So it is not very commonly performed. So next, coming to the spontaneous breathing trials, we have 3 of the commonest ones. That is the TPs trial. Here, supplemental oxygen is supplied through a TPs connected to an endotracheal tube. The next one is you have a CPAP trial. That is, you use a CPAP that is equal to the previous PEEP levels. And it's most commonly used in the pediatric population and in those who have COPD. And the next one is those who have been mechanically ventilated for a substantial period of time. You use a lower level of pressure support, that is around 6 to 8 centimeters of water. And the last one, which is commonly being discussed now, is about the automatic tube compensation, which is like a closed loop principle which adjusts flow for the assumed resistance of the endotracheal tube. It's not per se a ventilatory mode, but it can be added to the conventional modes. That is the one of the 3 modes that have been used. I really want to emphasize on one thing is SIMV is not a weaning mode and should be avoided. And in 2024, there had been a systemic meta-analysis that had come. They had shown that there is no difference between TPs and pressure support ventilation in relation to extubation failure or mortality. So either one of them can be used. So studies demonstrate that patients who fail an SBT do so within the first 20 minutes. So the success rate for an initial SBT is similar for 30 minutes compared with the 120 minutes. So this is the main rationale why they say whether you do it at 30 minutes or you do it at 120 minutes, it does not make much of a difference. So you check for the readiness testing, then you've initiated on an SBT. So the next thing is you have to assess whether the patient is going into a failure of an SBT. So the criteria for it is you have clinical assessment and subjective indices. That is, you see the patient, you see that he's getting agitated, anxious, or his sensorium is coming down. There is evidence of cyanosis that is setting in, or there is evidence of increased respiratory effort. That is like there is increased accessory muscle activity, facial signs of distress or dyspnea. If any of these features are there, then it must alert you that the patient is likely to fail an SBT and needs to be changed to control. But important thing is you don't go along with the subjective features alone. You need to also assess it with the objective parameters. So the objective measures, you go with first the respiratory related markers, that is the PO2 and the PCO2 and the pH. So first you take an ABG. In most of these, you will get the values. So the PO2 is less than 50 to 60 millimeters of mercury, or on an FiO2 of 0.5 or more, or SaO2 is less than 90%. once they've been put on SBT, or the PaCO2 is more than 50 millimeters of mercury, or there is an increase in PaCO2 more than 8 millimeters of mercury, or the pH is less than 7.32, or there's a decrease in pH more than or equal to 0.07 units. These are all important parameters that we need to keep in mind. Then we look at the other markers. One is the RSBA, that is if it is more than 105, respiratory rate more than 35 or increase more than 50%, heart rate more than 140 or an increase more than 20%, or a systolic BP more than 180 or an increase more than 20%, or a systolic BP less than 90. My bad, it's not more than 90, it should be less than 90, or presence of new onset cardiac arrhythmias. So if any of these vital signs are affected more than the reference range, then it should alert you that the patient is likely to fail an SBT. So just for a small revision, you check the ABG, you check the pH, PO2, and the PCO2. Then next, if the ventilator supports for it, you check for an RSBA and you check the vitals, the heart rate, respiratory rate, the BP, and you check the continuous ECG monitor for any evidence of new onset arrhythmias. So when you check the subjective and objective parameters, you will definitely get an idea whether the patient is likely to succeed or fail in SBT. So then you proceed for extubation. So when you plan for extubation, you need to look into 4 components. The first thing is you assess the optimal timing. Ideally, it needs to be done in the day. That's the time when most of the medical personnel will be available in the ICU. And in the event of any complication, they will be there to resuscitate the patient. Then also assess the potential difficulty with reintubation. Like if the patient is on sedation, obesity, or there was already difficulty with the first intubation. The next is to assess for the patient's airway protection, that is the mentation. Ideally, patients should be extubated awake, alert, following commands, and preferably off sedatives or with minimal sedation. But the problem is with the neurosurgery group of patients, those with GCS more than or equal to 8 are likely to undergo successful extubation. But in the event they don't do and they go into reintubation, then the next step would be to go with tracheostomy. I will be discussing it subsequently though. And then you need to assess the cough strength and assess for the secretion clearance. So for assessing the cough strength, you have an informal assessment and a formal assessment. So informal assessment is during deep suctioning. You may ask your respiratory therapist to suction and then assess how well they cough out the secretions, or how well the chest movement is during this cough responses. But that is very much subjective. The response that is being assessed by a junior and a senior may be varying. So there may be a potential for bias. Whereas you can go with a formal assessment, that is a spirometry, and you can check the peak expiratory flow rate. So if it is less than 60 liters per minute, there is a very high risk of extubation failure. So that needs to be looked into. And the next thing is that needs to be looked into is the secretions, whether it is thick or thin, and the volume. So the volume, it can be assessed from the canister and the bedside. And they say that if it is more than 2.5 ml per hour, that denotes increased secretion. So based on this one parameter, if you say it is becoming a indication that the patient may fail weaning, no. As long as the patient's mentation is good, it's not a problem. But in those who have a borderline or a low sensorium, they are likely to aspirate in these kind of scenarios. So this also needs to be looked in seriously. So the next thing is you need to assess for post-extubation stridor. So because if you extubated the patient and the patient goes into stridor, that is a bigger problem that you will have to face. So before you extubate the patient, if you look into the risk factors, perform certain tests, and then plan accordingly, then you may have more smoother course in regards to the extubation management. So with regards to the risk factors, they say that prolonged intubation, that is if it is more than 6 days, age more than 80, traumatic intubation, female 6, excessive tube mobility due to insufficient fixation, insufficient or lack of sedation, thereby causing the patient to frequently cough with the tube in situ, presence of aspiration or use of very large size tubes, that is more than 8 mm ID, and that's internal diameter in males, or more than 7 mm ID in females. So in these subset of patients, the risk of post-extubation stridor is very high likely. So I've made this list for an exam perspective. It is difficult to remember, but if you are able to reproduce at least 4 to 5 of this, it is good enough. The next is you have to assess for cuff leak test. And in whom do you want to assess the cuff leak test? In those whom the risk factors have turned out to be positive. So you have qualitative and quantitative. So you just in qualitative, you just deflate the ET cuff and auscultate over the upper trachea. So if you find that there is air movement present, that means there is cuff leak. That is supposed to be the most simplest test, but it is not foolproof. The ideal one will be to do a quantitative test. So you deflate the cuff, you measure the inspired and the expired tidal volumes of ventilator delivered breaths during volume control ventilation. So once you do that, the lowest three expired tidal volumes are averaged and subtracted from the averaged inspired tidal volumes. So the inspired minus the expired tidal volumes average has to be taken into consideration. And they say that normally, if the volume is more than 110 ml, that means the cuff leak, there is good amount of cuff leak and the risk of stridor is very low, or it should be 24%, more than 24% of the delivered tidal volume. So these two numbers should be remembered from an exam perspective, both for theory and practicals. I'm emphasizing it again, more than 110 ml or more than 24% of the delivered tidal volume. So if it is less than this, then there is a very high risk associated with post-extubation stridor. Anything else that can be done? Yes, you can proceed for an laryngeal ultrasound. The problem is it has not been validated yet. Maybe in the upcoming years, this can also be used as one of the markers that can be assessed for risk of post-extubation stridor. So if the cuff leak is negative, that is, there is no cuff leak that is present, then you go with glucocorticoid therapy. That is, there is two regimens. One is you go with methylprednisolone 20 milligrams Q4 hourly into 4 doses prior to extubation, or injection methylprednisolone 40 milligrams as a single dose 4 hours prior to extubation. Now, the important thing to mention here is this is as per the European Respiratory Society guidelines. In most of the centers, they do have their own protocols, but from an exam perspective, they will definitely ask you what is as per guidelines. So it is better to remember that this drug and this dose. So just for rapid revision, it should be methylpred 20 milligrams Q4 hourly into 4 doses prior to extubation, or methylprednisolone 40 milligrams as single dose 4 hours prior to extubation. So you've had a readiness to wean that was successful. You did an SPT that was successful. Then you assessed the pre-extubation risk factors. That was also okay. There was no any risk for extubation stridor. So then you proceed for extubation. So ideally, the patient should be in an upright position. There should be both clearance of the ET and oral secretions. Then there should be deflation of the ET cuff and removal. And O2 therapy devices has bridge based on risk factors for post-extubation respiratory failure. The most important risk factors are: one is patient with that age more than 65, or patients with already presence of diastolic heart dysfunction or diastolic heart failure. In these subset of patients, they are likely to develop Weaning-induced pulmonary edema. So in those subset of patients, it's better to put them on NAV post-extubation so that they do not further deteriorate post-extubation. So risk factors for extubation failure. So this also needs to be always kept in mind. The important ones are failure of 2 or more consecutive SPTs. So in those patients, if during the third SPT, if you're going to just go and try to remove the tube, you should always be clear in mind that there is going to be a potential risk that they're going to fail in the extubation phase. And then patients with chronic heart failure, especially those with a diastolic heart failure, PCO2 of more than 45 millimeters of mercury post-extubation, patients with a weak cough, upper airway stridor at extubation. We just discussed about it in the previous slides. Age more than or equal to 65 years. If pneumonia was present as a cause of respiratory failure, and the most important thing is if the patient is being extubated with a positive fluid balance on the day before extubation, then that is supposed to be a very high risk factor for extubation failure. Now, the important thing about I want to really emphasize is positive fluid balance it is problem both for extubation and also supposed to be associated with mortality also. So that is needs to be kept in mind. So you've seen the risk factors for extubation failure. So you need to know whether the patient is going into extubation failure. So the best markers that you can look into are your vitals. So if you see that the respiratory rate is persistently more than 25 for 2 hours, or the heart rate is more than 140 beats per minute, or there is a sustained increase or decrease more than 20%, or signs of accessory muscle usage of respiratory muscles is present, desaturation, that is a saturation less than 90 is there, or presence of hypercapnia setting in your ABG, in those situations, you can be well assured that the patient is likely to fail. So the next line of planning has to be done. That is either a reintubation has to be done, or the cause of this extubation failure, if the patient has developed a pulmonary edema or any other electrolyte abnormalities that are significant, needs to be looked into and corrected at the earliest. So we have spoken about weaning from mechanical ventilation. So you have extubated the patient, and then the patient again became distressed, and there was a necessity to reintubate. So you need to assess why the patient has failed weaning. So it is a very, very important topic, and I've made it into 3 parts. One is an introduction, the approach, and the management. So coming to the introduction, difficult weaning contributes to around 25 to 40% of weaning patients, and it consumes 1/3 of your ICU resources. And it's associated with increased patient discomfort, increased mortality, and increased ICU length of stay. So are there any markers that can predict prolonged mechanical ventilation? Yes, there is a criteria called the I-track criteria. So each of the letters denotes one parameter, that is intubation in ICU or hospitalized in ICU more than 24 hours, tachycardia with a heart rate more than 110, AK with the blood urea nitrogen more than 25, acidemia with a pH less than 7.25, creatinine more than 2, or a bicarb less than 30. So if 4 or more of these parameters are satisfied, it is very high likely that they are going to have a prolonged mechanical ventilation period of more than 7 days. So it is important to know about it. That is, one is the duration of intubation, tachycardia, AKA, acidemia, creatinine, and the bicarb. In this, 4 parameters are exclusively related to acid base and renal. So that is the best way of remembering it. So how do you approach to a weaning failure? It's very simple. It's almost like how you assess each patient in an ICU. You have to go in a holistic approach, assessing each system. So you go with cardiac, respiratory, neurological, psychiatric, metabolic, endocrine, and nutrition. So when you look into all this, there may be definitely one factor which may be contributing to the problem. So first we look into the commonest, that is the respiratory system related weaning failure. So the etiology can be either due to increased airway resistance, that is anything related to the tubes, small airway or a large airway, most commonly associated with bronchospasm. Or it can be due to reduced compliance, that can be related to the chest wall or the lung, which can be because of fluid overload, pneumothorax, pleural effusion, consolidation, or an atelectasis. So when do you suspect a respiratory cause? If you are treating patients come under the subset of a COPD or an asthma or an ARDS, or when you see that the patients that you're ventilating are having a reduced compliance, that is less than 20, or they are developing an intrinsic PEEP, that is an expiratory flow limitation, high respiratory rate, or there is loss of elastic recoil of the lung that can be elicited radiologically based on your X-rays, or there is patient ventilator asynchrony, that is ineffective triggering. If any of these features are there that you can be finding when you see the patient, then these are really issues that can be associated with weaning failure. And the important thing is they have found that intrinsic PEEP was found to be higher in COPD patients associated with weaning failure compared with those who had weaning success. So this intrinsic PEEP, if it is being present at the time of weaning, that is supposed to be a bad sign. It should be as low as possible, or at best, it should be nil. And the duration of mechanical ventilation was significantly longer in patients with ineffective triggering, that is more than 10% of all breaths compared with those having low incidence of ineffective triggering. So invariably, airway resistance related issues comes into these two factors, that is the intrinsic PEEP and the ineffective triggering, that is a consequence of this intrinsic PEEP. So how do you assess for this? One is, the best thing is you can auscultate the chest at the bedside and you assess for any presence of expiratory beads. Then you look at the flow time loops or the pressure time scalars, that is the trans airway pressures. And you can also assess for the intrinsic PEEP by using the expiratory pause. And for reduced compliance, you do an assessment based on the chest auscultation, or you can use lung ultrasound, like how Darshan had spoken about yesterday, that is use of the lung ultrasound score or present assess for presence of pleural effusions. Or if at all the patient is on mechanical ventilation for a long period of time with hypoxemia also, then it'd be necessary to do a HRCT to look for other pathogenic issues. So these are the two things I'd want to mention. Here you can see that the flow time scalar is there. Here, because of air trapping, there is a prolongation of the expiratory phase without returning to the baseline. And in the pressure time scalar, usually if you check the intrinsic PEEP, it will be higher, because the total PEEP is supposed to be the summation of your extrinsic PEEP and your auto PEEP. So when the total PEEP is very high in addition to your extrinsic PEEP, that means there is an addition of your intrinsic PEEP also. And here is an pressure time scalar and volume control ventilation, where you can see there is a marked trans airway pressure gradient. That is the peak airway pressure, and your plateau pressure variation is very significant. That this would be definitely more than 10 centimeters of water, which definitely signifies that there can be a airway related issue, that is in the form of a resistance. So you have identified either there can be a resistance issue or a compliance issue. So how do you go about it? So if there is a resistance issue, initial management is to go with bronchodilators and steroids. And if the patient is having intrinsic PEEP, if the patient is on pressure support ventilation, you modify the inspiratory cycle from 5 to 40%. Or if the patient is on control, you reduce the minute ventilation, increase the IE ratio if it is on control mode, or increase the inspiratory flow rates so that you allow the expiratory phase for a longer duration of time. And in advanced management, that is, despite your basic care, you are not able to achieve the target, then you will have to go with diagnostic bronchoscopy with the help of a pulmonologist. Whereas if it is a reduced compliance, we'll have to optimize it. So you will have to identify what the cause of it, whether there is presence of parenchymal issues, like there is edema that is present, or there is presence of pleural effusion, or there is presence of atelectasis. If there is edema present, you will have to go ahead with the fluid removal. If there is presence of atelectasis, you will have to keep more PEEP, encourage more chest physiotherapy. And if there is significant pleural effusion, that may be an indication for a thoracentesis. So this is about the respiratory, where we had to look into the resistance and the compliance, and how we identify and how do we treat the initial treatment and the advanced treatment. These were the components that we had discussed in relation to the respiratory part of it. So the next thing is we come into the cardiac evaluation, etiology. So the transition from mechanical ventilation to spontaneous breathing imposes an additional load on the cardiovascular system because of the intrathoracic pressure changes. Think yesterday, Dr. Bhuvaneshwari had spoken on the effects of positive pressure ventilation on the heart also. So this is based on that. So this affects the ventricular preload and afterload and increases the oxygen consumption by the respiratory muscles. So when you actually reduce the positive pressure ventilation, or the patient goes back into the negative pressure ventilation, it has an impact on these three factors. That is the preload, afterload, and the oxygen consumption. So weaning-induced cardiovascular dysfunction can occur up to 59% of patients manifesting as either a myocardial ischemia or a acute heart failure. So you have a patient with a cardiac etiology related weaning failure, when do you suspect it? In most patients who have a pre-existing cardiac disease or a COPD are the main patients, you will always have to have an eye on this. And just to show what the mechanism of weaning induced pulmonary edema is already they may be having a latent ischemia that is present that may not be obvious clinically. Once you put the patient on a SBT, the preload goes up, the afterload goes up, it causes more stress on the myocardium, thereby it leading to a manifest ischemia. So that will eventually lead to a decreased LV compliance with an increase in the LV afterload, and that can lead on to pulmonary edema. So when this pulmonary edema occurs, it will cause a decrease in your lung compliance, thereby causing an increase in work of breathing and eventually leading to weaning failure. So this is the main mechanism how this problem occurs. So how do you assess for it is, you go ahead with the 12 DCG before and at the end of the SBT, you assess for any STT changes that are present, and you also perform an echocardiography also at the same time. So in echocardiography, you can assess for regional wall motion abnormalities, or you can assess for any diastolic dysfunction. That is, you go with the E by E prime, which was discussed yesterday. And you also assess for any other history predisposing risk factors, and you exclude other causes also there along with your cardiac assessment. So once you do this basics, you then do a lung ultrasound to assess the severity, and you go ahead with cardiac biomarkers also. So most of the articles say you go with BNP, but bro BNP is also supposed to be good enough. So there was one trial that said that SBT induced increases in BNP levels more than 12% suggest a diagnosis of weaning induced pulmonary edema contributing to weaning failure with the sensitivity of 76% and a specificity of 78%. Though the numbers are not great, the thing that you need to take into mind is there is definitely a point that when this problem, that is the weaning induced pulmonary edema occurs, there is definitely going to be an increase in your BNP levels. So how do you go about the management? So you have an initial management and you go with the advanced management. In initial management, it's most of the things that you already know. You start on diuretics, keep a higher PEEP, you change them back to control ventilation. Then you go to afterload reduction therapies, like you use vasodilators like nitroglycerin if it is stable, patient's BP is stable, or you start on inotropes like dobutamine. And if ischemia is present and the acute heart failure part has resolved, then you consider beta blockers and you optimize the hemoglobin. If the patient has already had a recent MI, then you keep the HP target above 8. Or if the patient is having no previous history, then you try to keep the HP above 7 at least. That is based on the scenario. And optimization of the cardiac medications. And the most important thing, all this has to be done in conjunction and discussion with the cardiologist. And in advanced intervention, you can use levosimendan, because levosimendan has been shown to be a good drug when it comes to weaning induced pulmonary edema. And you can also use a pulmonary artery catheter if at all we need to assess whether there is any other issues associated with it, whether there is associated RV dysfunction in addition to the LV dysfunction that is also present. Though it is not routinely used, this is also one of the factors that can be used in conjunction. And cardiac intervention, that is a coronary angiogram, if it is feasible and if it is necessary. Again, this is at the discretion of the cardiologist. So we discussed about respiratory, in that we had spoken about resistant part and the compliance part. Then we spoke about cardiovascular. We had concentrated on weaning induced pulmonary edema and new onset myocardial ischemia that can be present and how we can proceed about it. So we had covered two and a half aspects. So the next part is about the neuromuscular. So you need to assess the diaphragm and the respiratory muscle function. So initiating a spontaneous weaning trial puts an acute load on the respiratory inspiratory muscles. The elevated load is imposed on a weakened respiratory muscle pump. So that point is very important. So already when they're on a long-term mechanical ventilation and you again put them on an SBT, there would have been already a significant amount of dystrophy that would have occurred. So when they again start to take their own breaths, there is going to be a tremendous amount of stress to the respiratory muscles. So when considering the inspiratory muscles as a cause of weaning failure, it should be kept in mind that dysfunction of the ventilatory pump may result from a lesion anywhere from the brain till the respiratory muscles. That is very, very important to be kept in mind. So impaired respiratory drive is an uncommon cause of weaning failure. In fact, in most weaning failure patients, respiratory drive is increased only. So you will actually find them to be more tachypnic than bradypnic actually. Occasionally, clinically relevant diaphragm dysfunction results from damage to the phrenic nerves. The most frequent disorder affecting the phrenic nerves is critical illness polyneuropathy, or most other common term is ICU acquired weakness. So when do you suspect neuromuscular? That is, patient is on long-term mechanical ventilation. That is more than 7 days. Patient has been on neuromuscular blockers, has been receiving steroids, sugars were uncontrolled, was receiving drugs that affect the neuromuscular pathway. That is like aminoglycosides, colistin. So in these patients, you always have to have in the back of the mind that the neuromuscular related cause of weaning is high likely to be there. So how do you go with the initial assessment? You go with serial neurological examination. That is to assess for other causes other than ICU acquired weaknesses. Then you do a PA max, P.1, and ultrasound assessment that you can assess the diaphragm thickness fraction and the diaphragm excursion. That is, diaphragm excursion in the patient is only on TPs. And advanced assessment can be done in the form of diaphragm fluoroscopy, nerve conduction studies, and muscle biopsy. So this slide itself will carry most of the points from a theoretical exam point of view, but many of the candidates may have certain queries related to PA max P.1. So I just wanted to clarify that. So the maximal inspiratory pressure, it's a global assessment of the inspiratory muscle function that can be obtained by measuring the maximal inspiratory pressure, right? So the lower limits for maximal inspiratory pressure in healthy subjects younger than 65 years is supposed to be lesser than -70 in men and less than -50 in women. So values more negative virtually exclude significant muscle weaknesses. But in most of the patients who are in ICU, usually they will have values that are actually supposed to be more than, that is, it goes more into the positive side, that is from -20 to -25. So in those category of patients, they are high likely to go into a weaning failure. The most important thing is when you do a maximum inspiratory pressure, there are going to be a lot of confounders because it depends on the cooperation of the patient and it depends on the lung volume. So if you've intubated a patient with a restrictive lung disease, or the patient is like in the form of an interstitial lung disease, this test is not going to be that good enough for evaluation. Then the P.1. So this is the most frequently used test to evaluate the respiratory drive in mechanical ventilated or spontaneously breathing patients. That is the airway occlusion pressure at 100 milliseconds. That is P.1. So the inspiratory limb of the ventilator is occluded and the drop in airway pressure is continuously monitored. In normal subjects, the P.1 is about 0.5 to 1.5 centimeters of water. So the important thing is in most MACVET ventilators, this provision is there for examination and calculation. So this can also be used as one of the tests that can be used to assess the respiratory drive. It should be noted that the P.1 depends not only on the respiratory drive, but also on the inspiratory muscle capacity. Accordingly, a reduced P.1 is not a very specific sign of impaired respiratory drive, but in patients with normal or high P.1, impaired central drive can be ruled out. So as I said, in neuromuscular related disorders, the issue can start from the brain, that's the medulla, and it can go all the way till the respiratory muscles. So if the P.1 is going to be very high, you can be well assured that the neural related, that's the CNS, that the brain related factors are ruled out. So when it comes to a diaphragm dysfunction assessment via ultrasound, you can go with the diaphragm thickness fraction. They say that if it is more than 30%, it is an indicator of successful weaning. And with the excursion, if it is more than 1.1, it is an indicator of successful weaning. So an important point to note is the definitive diagnosis of respiratory muscle fatigue after a trial of spontaneous breathing is not feasible in routine clinical care, because the development of hypercapnia during a venal trial is not a very specific finding, as hypercapnia may result from other causes other than respiratory fatigue alone, because there can be fever, or the patient may have central hypoventilation or rapid shallow breathing also because inadequate muscle activity. So You going alone with your ABGs alone for assessment of neuromuscular disorder may not be a good idea. And the absence of hypercapnia in a weaning failure patient virtually excludes inspiratory muscle fatigue. I think this is very much self-explanatory. So the management is early mobilization. Here, since ICU care is a multidisciplinary approach, the use of physiotherapists is very crucial for these subset of patients. Tight glycemic control is important. Antioxidants, which is more of experimental, there has not been proven evidence, and more time on support mode of ventilation, since it has been associated with reversal of ventilator-induced diaphragm dysfunction. So we had spoken about respiratory, cardiac, neuromuscular. Now the next thing about psychiatric. Now delirium or over sedation may limit ventilation, and it is because it causes a decreased cooperation with your spontaneous breathing trials. And the important thing to note is patients with delirium are twice as likely to be difficult to wean candidates. So when do you suspect delirium as a cause of weaning failure is previous history of dementia, delirium, substance abuse, long-term exposure to benzodiazepines. This is very, very important. And the initial assessment is to go ahead with the CAM-ICU score, and advanced assessment is to take an official psychiatric consultation for evaluation of depression or anxiety. So this is the CAM-ICU score. I think you are well aware about it. We will be having a discussion about delirium in the neurology modules. So I'm not going into discussion about this for now. This is just for your exam perspective, just to give an idea about it. So the management related to this is you go with non-pharmacological and pharmacological. In non-pharmacological, you have orientation measures, environmental measures, and clinical. In orientation, you provide visual and hearing aids, reorient the patient, and provide more patient attenders at the bedside. And environment, you give a good sleep hygiene, that is lights off at night, control excessive noise, early mobilization plus exercise and music. An important thing with excessive noise is to avoid alarm fatigue also. That is both for the patient and for the staffs. And clinical is to maintain an SBP more than 90 and to treat metabolic derangements, especially electrolyte and acid base. And pharmacological, you will have to go with dexmedetomidine. It has been shown as the drug of choice in management of delirium and ICU. And if you need to have more higher control, you go with atypical antipsychotics that in the form of quetiapine, olanzapine, or risperidone, or typical antipsychotics like haloperidol. So the next one is about nutritional. So we covered respiratory, that is resistive and compliance related issues, cardiac, neuromuscular. Now we covered delirium. Now we come to nutritional. So there can be problems related to underfeeding and overfeeding. In underfeeding, or increased protein catabolism, that is in patients with burns with high total body surface area or with severe pancreatitis, there can be severe decrease in your lean body mass, and that itself can cause respiratory muscle weakness. Whereas on the other side, you can have overfeeding, whereby there can be an increase in carbon dioxide production, and that can cause an increase in your ventilatory demand. So either way, it is supposed to be very bad, and those two problems need to be sorted out on a regular basis during your morning rounds. So when do you suspect a nutritional related cause of weaning failure is patients with pre-existing malnutrition, especially cachexic patients, those who have cancers, advanced cancers, or decreased gastric related issues, or patients who present with high severity of illness, like an Apache 2, based on the Apache 2 score, especially those with an Apache 2 score more than 25, that correlates with the 52% risk of mortality. Those patients are likely to have MODS, and they're going to have a long-term length of ICU stay. So in those subset of patients, they are going to be going into a catabolic state very easily. So it needs good monitoring and early feeding. And important thing is nutritional causes of weaning failure should be considered only after the common causes are ruled out. And the best measure of assessment is to go with the indirect calorimetry. And how do you manage it is, if it is underfeeding, you provide for adequate energy intake. And if it is overfeeding, whereby there is increased carbon dioxide production, you come down on your nutritional intake. It's as simple as that. Then coming to metabolic, it can be because of electrolytes or endocrine related. Electrolytes, most commonly because of hypophosphatemia. They say usually if it is less than 0.6 milligrams per deciliter, or hypomagnesemia and hypokalemia, that is severe hypokalemia, that is less than 2.5, with presence of metabolic acidosis. All these four conditions can precipitate skeletal muscle weakness. And corticosteroids, it can cause ICU muscle weakness, and it can also cause hyperglycemia, which can further precipitate muscle weaknesses. So the ultimate problem is skeletal muscle weakness that occurs because of all these electrolyte and endocrine abnormalities, and that is going to cause difficult weaning. They do comment that hypoadrenalism and hypothyroidism can contribute to weaning difficulty, but it is been very rare and it is not very commonly seen. It is more of a rare causes, but it should be kept at the back of the mind in scenarios where you have done an extensive evaluation and you have not been able to come up with a adequate diagnosis as to weaning difficulty. So when do you suspect metabolic causes? After cardiac, respiratory, neuromuscular, and psychiatric causes are ruled out, and you find out there is severe electrolyte imbalances that are present. So the initial assessment is to go with serum electrolytes and ABG, and advanced assessment is to go with plasma cortisol levels and thyroid function tests. Like I said, it is only after you rule out all the common causes, you assess for the endocrine abnormalities. So the management is to go with IV electrolyte supplementation plus or minus hormonal supplement in the form of steroids or thyroxine. But the good thing with electrolyte related weakness is once you correct the cause, usually the muscle power improves very drastically. So we have assessed respiratory, that is the resistant related and compliance related, cardiac, neuromuscular, delirium related. Then we assess nutrition, metabolic electrolytes, and we assessed for hormonal, that is endocrine related, thyroid related, hypothyroidism or hypoadrenalism. So once you've looked into all this, you get a holistic approach into the cause of difficult weaning. So once you've addressed it and you've treated it and the patient still requires long-term mechanical ventilation, the next thing is to decide about the role of tracheostomy. So the advantages is easier airway management, reduction in sedation use, earlier weaning from respiratory support, improved respiratory mechanics, earlier transition to oral feeding. But as long when there are goods, there is definitely going to be bads. So the complications are misplacements, which can be very life-threatening. There can be bleeding, there can be obstruction, infections, and tracheal stenosis. This is very relate, and it is a very uncommon complication. The optimum timing is still unclear because the TrackMan trial has shown that whether you do it at 4 days or you do it at more than 10 days, there has not been any difference in your mortality. And the techniques is you go with either a percutaneous technique if your ICU does it on a regular basis, or you can go with the surgical technique that is done either by the ENT surgeon, the neurosurgeon, or a general surgeon. Thank you. So any queries, please upload it in the chat box. I will answer it in the subsequent talks. Or if it's no times available, then I'll reply it through WhatsApp.
Okay, Srihari, thank you. That was quite extensive and very clear, I think so. If there are no further questions, we shall continue with the next talk. I think so. If you can stop sharing your screen, then I'll start sharing mine.
For sure.
Okay, thank you. So good evening, everyone. So going to the next topic, which is there for today, there are a couple of topics which have been lined up. So the first thing which I would like to start off with is the topic which has still not come for the answer this thing questions yet. So is my screen visible?
Yes, Darshan.
Yeah, okay. So coming to one of the topics which have been quite contemplated in most of the conferences of lately, that is patient self-inflicted lung injury and the concept of mechanical power. This question can be asked either as a question in the first paper where physiology is mostly the thing which they focus on, because most of the other concepts have already been asked in the respiratory system. So there have been questions in formative assessment tests in a few centers where they've asked this question. Apart from that, they have still not put this question in the DM or DRND papers as of now. So what is patient self-inflicted lung injury or mechanical power? So these two things are something which are correlatable. Okay, so from the outline of the talk, I would like to start with the concept of Psili, going on to pathophysiology, the determinants, and the clinical application of Psili. So the concept of Psili comes from understanding that the lungs and the bronchial epithelium usually serve as the first line of immune defense. It includes both the innate and the adaptive immune systems. What usually happens is whenever there is a breath that has to be taken, it is dependent on the energy, and that energy is the requirement, which usually is the pressure difference, that is the gradient between the alveoli and the atmospheric pressure. So based on this pressure gradient, the lungs get distended. So these things, the gradient or the energy is dependent on three things, that is the respiratory muscles, if the patient is breathing spontaneously and is hale and hearty, or if the patient is sick, might be by a ventilator. And when the patient is in an ICU setting requiring a ventilator, it is by both the respiratory muscles as well as a ventilator. Sometimes in a more like a morbid patient, if the patient is an old COPD patient or someone like a patient who has been had a severe acute asthma attack, when we initiate NIV, even then the energy is usually calculated based on the distensibility of the alveoli. So during mechanical ventilation, the work of breathing, which results in distension of the alveoli, depends on how well the patient is able to tolerate the stress. So if the patient is not able to tolerate that and the ventilator provides an additional energy which the lung is unable to take in, it leads to a condition called as ventilator-induced lung injury. So there are a lot of things which are involved in the ventilator-induced lung injury. That usually is one of the bases why the lung protective ventilation came into picture. So lung protective strategies were usually based on low tidal volumes, that is usually less than 6 ml per kg as by the ARMA trial, plateau pressures less than 30 centimeters of water, driving pressures less than 15 centimeters of water, and optimization of PEEP. All these things were shown to have some amount of mortality benefit with patients with ARDS. So what is Psili and mechanical power got to do? Like with all of this, we already know there is a ventilator-induced lung injury. So how is it so different from a VILI? So what usually happens is the mechanical power concept was introduced for calculating the energy applied by the respiratory tissue during the mechanical ventilation. We were looking at from the other end. We were looking at what happens when the ventilator gives it to the when the ventilator is delivering the pressure to the patient, but not understanding the energy concept. The exact measurement of driving pressure, tidal volume in patients who are breathing spontaneously has significant limitations. And the clinicians must be aware of excessive signs of work of breathing and respiratory effort when they put this into picture. So Psili usually, more commonly happens in spontaneously breathing patients. It can be either by a patient on an endotracheal tube, patient on an NIV, or even patients breathing without any ventilatory support. So what usually happens, like Srihari was mentioning in the previous talk, right, about weaning. So there was a lot of talk about respiratory drive. So whenever the patient is having an increased respiratory drive, I would like you to, look at the cartoon on the right side of the screen. So whenever you have a patient with increased respiratory drive or an increased respiratory effort, this usually leads to some amount of ventilator dyssynchrony. Obviously, the ventilator takes in some time, even with the best ventilators and the closed loop ventilators, the adjustment takes some time. In between the adjustment, there is some amount of energy transmission which happens, which is usually not required to the patient. And this is conceptualized to have caused Psili. So what are the other problems which usually happens when the ventilator delivers? There is a phenomenon called as pendlift. Okay, I'll be explaining pendlift in detail in the coming slide. And there is usually an inappropriate stress and strain which is delivered across the lung. So because of this dyssynchrony concept of pendlift and inappropriate stress and strain through the lung, the patient ends up having a lung injury. So this whole thing, it becomes a vicious cycle if it is not controlled. And this leads to probability of hypoxia, hypercarbia, inflammation. That leads to lung edema. Again, based on all the other feedback loops, your chemoreceptors or baroreceptors, these gets kicked in and the respiratory drive increases. So if you're not containing this initially itself, this goes into a vicious cycle, causing more stress and damage to the patient. So all that you need to remember is when a patient comes, there is increased respiratory effort because of a pathology. There is when you initiate ventilation, more or less because the energy delivered is inappropriate to the amount required. The patient has some amount of ventilator injury or lung injury. That again, if not corrected appropriately, leads to a vicious cycle and ends up in more damage in a hyperinflammatory state. So I spoke to you something about pendlift. So what is pendlift? You have a lung. The lung usually gets ventilated. If you see, there are two images on your screen, right? One is actually these images are taken from electrical impedance tomography. Okay, so electrical impedance tomography is one of the imaging modalities which helps us understand how ventilation is done when we deliver a breath. Okay, so these helps us to understand even the ventilation perfusion also. So what usually happens is there is one normal tidal variation, and when there is pendulum, that is what you need to understand. So there is a part of lung. Imagine that the patient has pneumonia, okay, and it is in the lower zone. For a practical or an example sake, we'll take it to be a left lung pneumonia, okay, and it is the lower zone which is get involved. So that becomes a dependent part, and the dependent part itself has pneumonia, right? So preferentially when a breath is delivered, if you see the EIT, right, first part of the lung to get ventilated would be that part of the lung, that is the dependent part of the lung, that is by the solid gray line which is there. And then the other part of the lung gets ventilated, that is the non-dependent part of the lung, if this patient is assumed to be lying in supine position. Okay, so what happens is there is improper or uneven distribution of ventilation across the lungs, which happens in a case of pneumonia or in case of an ARDS, which is seen. So this phenomenon of improper distribution of air to the dependent areas primarily, then moving on to the non-dependent areas, is called as pendlift. I repeat, the phenomenon of delivery of tidal ventilation first to the dependent area, then moving on to the non-dependent areas, is called as pendlift. So there will be an inappropriate hyperinflation of the non-dependent areas, and because the dependent areas are having the pathology, sometimes they might not get ventilated. Okay, so how would you usually assess all these problems? So whenever you have patients, there are a lot of scales which are available. So if based on the patient being on a ventilator, spontaneously breathing, patient being on an Hfnc, okay, or NIV. So I have discussed about all of this previously as well, right? So whenever the patient is having NIV, you can use a Eccor score to know how bad the patient is. Or like Srihari was mentioning earlier, when you're using weaning indices, P.1 becomes one of the easier methods to understand the respiratory drive. So going again to explain about P.1, if you have a P.1 between 1 or 2 centimeters of water, that is roughly around a normal respiratory drive. If you have a drive of more than 4 to 5 centimeters, it is an increased respiratory drive, indicating that the patient is actually breathing fast, or the patient is having higher work of breathing. So these things triggers an inflammatory process in the lung, which can worsen the ventilator perfusion mismatch, which further worsens the ARDS, which further worsens the clinical status. Okay, so this is what they have postulated to be the concept of Psili. So, based on all these understanding, this was a recent article published in Journal of Intensive Care in 2024. So, by this, we have already understood that if the patient goes into a vicious cycle of Psili, that the damage caused to the lung would be more. And instead of benefiting from our interventions like NIV, HFNO, or ventilation, we would be doing more harm. So, what are the recent advances in the cardiorespiratory monitoring, which is supposed to be implemented in case of ARDS? The one which they have spoken about is the use of mechanical power, along with other surrogate markers like the PF ratios, the use of tidal volume challenge test, PEEP, uh, ultrasound evaluation, etc. Okay, so this is one of the things which they have incorporated in the recent guidelines for cardiorespiratory assessment in the patient who is on ARDS management, be it on ECMO or off ECMO. So coming to the understanding of mechanical power. So I've already spoken to you about the pathophysiology of Psili. So this usually is a part of lung injury itself, and lung injury, as I've told you, can be caused by either volutrauma, atelectotrauma, oxygen toxicity, shear stress, biotrauma, or barotrauma. It invariably affects the alveoli. So the current understanding of mechanical ventilation and managing the patients on a ventilator requires a precise and personalized approach. So more or less, we are coming to precision medicine in critical care. That is one of the strong backgrounds and pillars for the concept of mechanical power. Okay, and this is usually for understanding that we cannot, standardize and make one size fits all policy for all patients with ARDS. The previously understood concepts of tidal volume, driving pressure, plateau pressure would not be sufficient for us to attribute for lung protective ventilation. So the concept of mechanical power, which is an energy-based assessment of lung injury, is something which has been postulated, and morely it includes patients' spontaneous efforts causing the injury rather than the ventilator alone. Okay. So Psili, a patient self-inflicted lung injury, is mostly due to increased respiratory effort and work of breathing, which symptomatically can be determined by the respiratory rate in the bedside. Okay, so I think so. This slide kind of summarizes what I have told you previously. I hope you guys are with me till here. What is the aim of mechanical power? The concept of mechanical power was to quantify the contribution of respiratory rate and PEEP to the total power delivered to the by the ventilator. So it usually aggregates three variables. That is the physical measure, which helps us to understand or correlate to the risk of ventilator-induced lung injury. So usually whenever we have ventilatory parameters set in, you usually have both this, dynamic parameters as well as static parameters. So static parameters I've already mentioned before, and the dynamic parameters are the ones which we have to think about. That is the respiratory rate, inspiratory and expiratory airflow, which leads to the cause of ventilator-induced lung injury. So for practical understanding, how we can apply mechanical power, usually you have a patient, you start with the left hand side, you intubate the patient, you do lung protective ventilation based on the predicted body weight, that is 6 ml per kg, adequate PEEP, and P inspired less than 30, you have your driving pressures less than 15, plateau pressure less than 30. Okay, so based on this, you ventilate the patient, but you are unable to reach targets, and you're having a higher driving pressure, you're having a higher airway resistance, your compliance is still low. Probably at that time, you might have to evaluate as to what is the cause of the problem. Okay, if you see there is a non-homogeneous spread of lung damage across both the fields, then the concept of mechanical power can be implemented. That is when the patient's ventilatory settings have been optimized. Once we do that, you're not able to get a patient. More or less, we have seen this scenario in our practical approach, right? You have tried to achieve all these targets. Based on this, you're still not able to do. You prone the patient. Despite proning, you're not seeing any improvement. Is there any other method which will justify the implementation of ECMO? Yes, mechanical power. But if you see that after all your lung protective ventilation proning, and your PF ratio is still less than 150, you can still use mechanical power as a surrogate. If the mechanical power is less than 7 joules per minute, probably you can still continue on this mode and wait for some time. But if you see that it is more than 15 joules per minute or more than 12 joules per minute, then the consideration of ECMO becomes something which is substantiable or justifiable. So this is how we can implement the concept of mechanical power. I'll be again discussing it. Okay. So what is the definition of mechanical power? It is defined as the product of respiratory rate and total inflation energy gained for the ventilation monitoring. Okay. Inflation energy usually comprises of airway resistance, lung and chest wall movement, and end expiratory pressure related recoil of the lung and the respiratory system. So it comprises of three components. That is the elastic related component, resistance related component, and PEEP related component, multiplied by a constant that is 0.098 as well as respiratory rate. Okay. So by looking at this, most of us would be thinking, can I remember this formula? Is it required for us to remember? Absolutely no. There are simple formulas which are available, and there are ventilators which are coming up, which are actually including these algorithms. It's in the weaning modes itself, where you can check the mechanical power. So that is the level which they're trying to implement it. In simple terms, power is the transmission or conversion of energy. It's defined as work over time. In mechanical ventilation, the power of each breath is the area under the pressure volume loop. Okay, if you jot down a pressure volume loop in your ventilator, the area under the curve is the power for that particular type of mode of ventilation. So it is measured in joules per minute. Normal is around 2 to 3, up to 7 is acceptable, more than 15 joules per minute. So if you see in a patient with on mechanical ventilation, you can still give them the trial of all the lung protective strategies. If it goes more than 15, probably you might have to consider thinking of alternate strategies. Okay. So whatever the energy expenditure is present in the ventilated patient, it's usually to increase the functional residual capacity. But if it goes beyond that, usually that is because of the muscle contractions which are being present to compensate the work of breathing. Okay. This is observed that during spontaneous ventilation or even during artificially ventilated patient, ventilator generates an airway pressure. The mechanical energy is usually the sum of potential energy and kinetic energy, which is simple physics, right? So this mechanical energy depends on the position where the inspiratory effort starts. So if you see that it's a difficult situation where the alveoli is fully collapsed, right? If you have a partially distended alveoli, the effort required to distend the alveoli is lesser. Okay, this is one of the concepts which they are trying to tell. That is, the energy required to start a respiratory effort depends on the position where the effort starts. And it also depends on the driving force. That is the driving pressure. Okay, that is usually correlatable to the movement of the chest wall. That is to overcome the elastic and the resistive component of the ventilator. So usually we have spoken about the mechanical component of mechanical power. So we are talking about the kinetic energy. That is, whenever we have the energy which is present, it has to overcome these both elastic and resistive forces to generate the power. And the lung has to take a breath. So this is one part of the component which comes in to help to generate a breath. This part of the component is usually attributed to the PEEP. So there are various formulas which have been postulated. I told you that formula which initially I showed was looking very scary, but there are other formulas which are available, which is simplified. And it is present for both volume control ventilation, and it is also present for pressure control ventilation. Okay. So these are simplified so that they can be applied in the usual bedside. So whenever we talk about, mechanical power, Psili, Willi, anything like that, we need to understand that it depends on how the energy is transmitted across the lung and how the lung responds to it. For example, you can take a eraser for instance. Okay, you have a normal pencil eraser as well as an ink pen eraser. You have seen the tough blue color erasers, right? So if you see the energy, if you apply pressure on the white color erasers or the pencil erasers, you can easily indent. The eraser is able to deform waveform, but it's able to take the stress. But if you apply some amount of energy, the blue eraser cannot take that much energy, or if you go beyond a certain point, probably it might break. So here, application of energy is from the patient. Okay, so if you imagine like that, if the patient is having a bad lung and is trying to apply more energy, probably is unable to take that stress, and it ends up causing more damage to the patient itself. So the lung surface, more it is able to accommodate the energy which is transmitted across the airway into the alveoli, it is better. That chances of Willi will be less. But if the same length of power which is required, and the lung surface is not able to take in that energy, then the chances of Willi goes up. Okay, the possibility of to develop Willi solely doesn't depend on the lung surface alone, but it depends on a lot of other types of ventilation. Like I was telling you before, like closed loop ventilation, there is a closed loop, that is the ventilator is able to understand the respiratory drive. The patient is able, the machine is able to understand the respiratory drive. The machine is also able to understand the respiratory effort. So based on this, the next subsequent breath would be adjusted, or it is like an adaptive ventilation. So whenever you have such closed loop ventilation, the damage caused because of the ventilator and patient synchronization or dysynchrony would be reduced. The simplest method would be to use a respiratory rate, tidal volume, and the PRS, delta PRS. Okay, that is usually the resistive forces and the elastic forces. So many authors, including the Accuracy trial, Proseva trial, and even Guerin and multiple studies have found that power about 12 joules per minute was associated with reduced survival. So power is not something which has been done like 5 years or 6 years back. It was done at least a decade and beyond that. Zhang et al. Found that mechanical power of 3 joules per minute per kg body weight was safe. So there is no safe threshold. That is what I want you guys to understand. Okay, there is still a lot of data and research going on in this to get the sweet spot, but they have not been able to come to a correct understanding. If you've seen previous slides, I told you 3 to 5 is normal in normal breathing, then roughly 15 to 20 is in mechanical ventilation is okay. That's why there is a huge discrepancy. They're not able to get the exact number. Like in driving pressure, it was very clear, 15 to 18, more than 18 is indicative of a poor outcome. Similarly, they're not able to get one value in mechanical power. That is one of the limitations in mechanical power, or the application of mechanical power. So is mechanical power a game changer? That is something that we need to know. So various studies have been done, and if you see this a graph here, it usually mentions the odds ratio, and there are a lot of other parameters which have been taken into picture, like driving pressure, power, and elastic, and or the elastic and dynamic components. So if you see these things, power does not seem to be doing better than driving pressure. So from the evidence which is currently available, driving pressure was found to be 4 times better predictor of mortality as compared to mechanical power. In mechanical power equation itself, the elastic component was better predictor of Willi as compared to the other components, that is resistance and PEEP. So the study also looked at various other parameters which helped in association of mechanical power with standardized mortality, and they couldn't quite establish that mechanical power was superior to the already available predictors. So how do we apply the mechanical power in our day-to-day practice? So this graph helps us understanding. So you have a patient coming into your ICU. Patient gets ventilated, you start mechanical ventilation, lung protective ventilation is initiated on this patient. You measure all the pressures like plateau, driving, and power. You see that the patient is not improving, the PF ratios are going bad, and you start proning the patient, you optimize the PEEP and try for a closed loop ventilation if available, then you still continue using power. Okay, at this time you also reassess driving pressure. If you see that the driving pressure is going up and the power is also going up, probably the energy required to generate the breath is going up, and this might lead to further inflammatory process worsening ARDS. So this would be one of the places where you can think of referring the patient to an ECMO center, or if your center has ECMO, to initiate ECMO. Okay, this is one of the practical approaches for mechanical power. So coming to the summary, it is not a novel tool. It has not seen to be better than driving pressure. It's still a conceptual, point of view which is being put across. So more data in mechanical power is necessary because most of the data which is already presented is based on retrospective analysis. So we need to do a prospective larger trial to know whether this alone can replace most of the other parameters and use as a single tool. Okay, thank you. All that you need to know in power is it's energy dependent. It's based on patient self-inflict like lung injury. You would have an elastic component, a resistive component, and the respiratory drive. It is almost correlatable to driving pressures. If you find that the patient is having increased energy requirement as attributed, in those formulas wherein the total calculated power of more than 12 joules, it's indicative that the patient is worsening with ARDS, and this can be a practical tool for initiation of ECMO. The limitations, no widespread data. It is not superior to driving pressure. Most of the data available are based on retrospective studies. So these are the few headers you can put the answer under when they ask you about mechanical power. I've tried to simplify this. I myself had to rack my head a lot when I had to understand this. I hope this helps. If any other questions are there, I'll be free to answer now or in the chat box. Any questions?
No questions has been uploaded so far, Darshan.
Okay. Thanks, Shriyari. I think so. I'll go ahead with the next talk. So, is my slide visible?
This is power and Psili alone is there. The new slides, I don't think has been uploaded yet.
Is it? Okay. I can see this. Just a minute. Prone ventilation is not coming, is it?
No, not yet.
Now is it visible?
Yeah, now it's visible, Darshan.
Okay. So continuing with the next talk, that's on prone ventilation. So there have been a lot of practical questions which are there. Usually this question is something which you get asked bedside each time. What are the basics of prone ventilation? Why do you do prone ventilation? How is it better? What is the evidence, etc.? There's been only one question in the last DM paper which they've asked, that is the evidence of ventilating a patient in prone position and improving oxygenation. So this is the only thing which I could get across in all the papers that we had referred to, and we wanted to help you guys understand the concept better. So coming to the introduction of prone ventilation, proning is one of the only evidence-based technique to affect the mortality of ARDS patients. Prone ventilation, improves lung compliance and the ventilation perfusion matching by reducing the posterior atelectatic lung. The heart and the anterior lung fields are placed down instead of acting with gravity to compress the larger part of the posterior lungs. Therefore, more lung parenchyma is ventilated and the fixed tidal volume in the lung will suffer less barotrauma. Okay. So understanding this concepts becomes very important. Okay. So if you see the slide, we have a patient who, forget about ARDS, forget about a pathological lung. Look at the normal lung itself. Okay. You have a patient who is in supine position. You have a patient with prone position. When you have supine position, you see this part of the lung is actually larger part of the lung, correct? And you have the heart anteriorly and the vertebra posteriorly. Once we prone this patient, this larger part of the lung is where we are actually looking at for recruitability when the patient has some pathology or ends up in ARDS or pneumonia. So why this part becomes more important is because of the activation of gravitational forces, the pressure exerted by heart on the mediastinum on the lungs and the mediastinum on the lungs gets decreased. Okay. Similarly, there are other issues which are also present, especially if you see the contribution of the abdominal viscera, especially the liver, even that actually reduces when the patient is put prone as compared to supine. So when I say that why this happens, I'll come in depth about these concepts later on. But what you need to understand is there are two parts if you have to look at it. Okay, one is the expansibility. The posterior part of the thoracic cage is actually less distensible, or you need to understand that it is more stiff. That is the vertebra and the rib cage posteriorly. But if you see the anterior part of the lung, that is the sternum, it is more or less better, or it is less stiffer and it is more deformable. So whenever there is a chance for expanding, whenever it is required, like if the patient takes a deep inspiratory effort, the anterior part of the chest gets more distended as compared to the posterior part of the chest. Okay, so this is one of the reasons which has been attributed for the benefit of ventilation when the patient is put in prone position. Okay, so this is the basic simple understanding you need to understand. Anteriorly, the distensibility is easier because it is less stiffer. Posteriorly, because of the vertebra and the rib cage, it is less stiffer and the distensibility or deformability is lesser. Okay. So how does prone ventilation help? The most important things that we need to remember is under these headings. It helps in improving gas exchange. It helps us in clearance of carbon dioxide. It helps us in improved lung mechanics. So how does it help in lung mechanics? I'll come in detail later on. And it also helps in hemodynamics. Okay. Coming to the gas exchange. So what do we usually mean by gas exchange? It is either looking at an oxygenation or carbon dioxide clearance when we are talking about ARDS, right? So that was one of the reasons why proning was done. Proning was done way earlier itself. Brian did it around 1936, and a lot of other trials came in 1980s and 90s. But the actual thing about studies with prone ventilation started in 2001. Okay, so all of these studies were focusing on mostly oxygenation, and subsequently, because they were thinking about oxygenation, they were also looking at carbon dioxide clearance. So how does proning help in gas exchange? So if you're talking about oxygenation, that I told you there is a dorsal recruitment and preservation of perfusion. So what happens is we need to understand whenever we put the patient prone from supine to prone position, the perfusion of the posterior part of the lung does not change. The perfusion remains to be the same. You might be thinking because of gravitational efforts, the blood tends to pool in the anterior part, but that doesn't seem to have happened. There have been large number of trials which have been conducted, which has shown that the perfusion remains to be the same in the posterior part of the lung. Okay. So on the other hand, because of proning, the dorsal recruitment of the alveolar component that increases. So this reduces the VQ mismatch. Because this reduces the VQ mismatch, the oxygenation improves. Okay. So coming to carbon dioxide clearance, usually whenever you talk about carbon dioxide clearance, it can either be present or it can be absent. What do I mean by absent? Usually the PaCO2 is similar to in both prone or supine position, or else it is more in prone position as compared to supine position. But if the carbon dioxide clearance is present, because of proning, the carbon dioxide level would have decreased. So how does this happen? Usually because of recruitment, the ventilation improves. Correct? Once the ventilation improves, there is better carbon dioxide clearance. So if the patient gets recruited better, only then the CO2 clearance would have happened. But if the CO2 clearance has not happened, there might be other causes which we need to evaluate. So we shouldn't tell that the proning alone is ineffective when CO2 clearance is not present. But having said that, we need to closely monitor this patient. How does proning help in lung mechanics? So we finished gas exchange. We are going to talk about mechanics. Okay. In lung mechanics, we have something called as homogenization of transpulmonary pressure, thorax and lung shape mismatch, and lung mass distribution. These are the three headings that we need to understand under. So what do I mean by homogenization of the transpulmonary pressure? So this picture actually helps you to understand prone ventilation, physiology in depth. So I was talking about the perfusion and ventilation. The blue things here, the circles, are something like the alveoli. Okay. So the red, wherever you see red, it is the perfusion. Okay. So if you see a triangle, it is an isolated lung. But if you see a box, it is the lung inside the thoracic cage. Okay. So imagine the patient is in supine position. Okay. So when the patient in supine position, you can see if you take an isolated lung, it is uniformly distributed, right? But if you have a patient inside the thoracic cage, what happens? The anterior part of the lung gets hyperinflated, whereas the posterior part of the lung is not ventilated well. Similarly, when the patient has a lot of pneumonia or some other perfusion mismatches, oxygenation is also hampered. So even the ventilation also will get hampered. Okay, so this is what is the concept behind proning the patients. So we know one thing: you see the blood flow, correct? So whenever we have the patient in prone position, the blood flow, if you see this gradient here, it is better on the posterior part, it is decreased on the anterior part. Okay, so the same thing happens here. If you see the gradient here, this blue part is actually lesser flow. This is better perfusion. If you see, we have prone the patient here. What happens over time is because of gravity and shape matching, this homogenization, which we saw in an isolated lung, happens. Okay, this is what is the advantage of proning, and this is what happens when we have homogenization of the transpulmonary pressure. So why am I talking about transpulmonary pressure a lot? So that is the pressure which is required to have a breath delivered to the alveoli with minimal effort. Correct. So this is what is achieved by proning. So what do we mean by thorax lung shape mismatch and lung mass distribution? So this is something that I've already spoken to you about. When you have the patient in supine position, because of the stiffness of the lung, whenever the patient takes a nice deep breath, it usually, or whenever we give a ventilatory breath, it preferentially ventilates the anterior components, and the posterior part of the lung is not ventilated. Whereas when you put the patient in prone position, because of recruitability and because the anterior part is becoming dependent, it has chance to expand. I will repeat it again. Because in prone position, the anterior part of the chest is the dependent part, that is lower down, that is sternum is below. It can expand. It is less stiffer, right? So it homogenizes both ventilation as well as perfusion. This helps in better lung mechanics also and better oxygenation and gas exchange also. I hope you are clear till here. Okay. So this is a shape, this is a slide which will help you understand. So in supine position, more or less everything is mismatched and there is no balance. And when we prone this patient, there is both shape matching as well as, effects of gravity and superimposed pressure, which is balanced in prone position. There have been a lot of talk about hemodynamic changes in this thing, prone position. So coming to hemodynamics per se, there is one thing which I've already made it clear: there is no change in regional circulation, especially the pulmonary circulation. All that happens is change in systemic circulation. It has been postulated that there is an increased CVP. That is because whenever you have a patient on prone position, if they are not optimized properly, then this wouldn't happen. But if they are kept exactly in the horizontal position, then there is a shift of blood from the splanchnic circulation into the central circulation, which increases the pulmonary arterial occlusion pressure. This usually helps in pulmonary vascular recruitment, decreases the physiological dead space. It converts West Zone 2 to West Zone 3. And this usually helps in increased carbon dioxide clearance. That is because it decreases the hypoxic pulmonary vasoconstriction, decreased alveolar pressure, and decreased pulmonary edema. And this leads to homogenization of the ventilation and perfusion. Okay, so this is what is the advantage when we prone the patient on the hemodynamic front. Okay, so this was one of the studies which was recently given from the European respiratory monograph. This is the first study by Gattinoni, that is in 2001. Okay, and this is the one which is recently published by the same author. Gattinoni himself published it a year ago in 2023. Okay, so this is a beautiful picture which summates whatever I've said right now. In supine, you have a low PaO to FiO2 ratio, increased PaCO2, low lung compliance, and it is a heterogeneous lung aeration. But in prone, what happens? Because of the prone positioning, there is increased PaO to FiO2 or better oxygenation, decreased PQ mismatch, better clearance of carbon dioxide, the compliance of the lung improves, and there is more homogeneous lung aeration. Okay. So based on all of this, what is the data that we have? How does it reflect on the ventilator settings? So if you see the patient's PaO to FiO2 ratio in a supine position before proning, these were the settings which were seen. This is in a study by Guerin et al. Okay, so what they noticed was the PaO to FiO2 ratio was around 74, CO2 was around 54, P plats were around 27, and driving pressure was 21. As soon as they prone this patient, for 18 hours in the study by Guerin, what they found out the PF ratio improved. PaCO2 reduced, plateau pressure and driving pressure also significantly reduced, indicating that the recruitability was better and the damage caused to this lung would also have, subsequent effects. So, what are the indications? When and in whom would you think about doing prone ventilation? Can anyone unmute and say what do you usually do? Because all of us, I hope, are doing prone ventilation, right? So please let it become less monotonous. When do you do proning? What is the evidence? Okay, without wasting further time. So the indications whenever they have been shown are based on the Proseva trial itself. Okay, there have been a lot of trials which have been done with recruiting patients between PF ratio of less than 200, PF ratio of less than 300, and PF ratios less than 150. So the best result which they found out was when the patient is prone after adequate lung protective ventilation being done, and despite that, if the PF ratio is less than 150, recruit these patients, put them for prone ventilation at least for 16 hours. When you do this, you have to have a lot of other checklists which are available, and post that the patient is seems seen to have better results. So this is usually mostly based on the PF ratios that is less than 150. After you have optimized the P, FiO2, etc. Whenever you have a PF ratio of less than 150, you need not wait fully for the FiO2 to be 100% to get that ratio. Even with an FiO2 of 0.6, if your PF ratio is not good, you can still start recruiting this patient. Okay, try and optimize these patients. If you're not able to get the achieved PF ratios, then probably this patient is an ideal candidate for proning. You need not have an 100% FiO2, PEEP of around 14 and all the other PEEP recruiting strategies to be present. You can give all your lung protective ventilation for probably 12 to 18 hours. And if you don't see this in supine position, early recruiting into prone ventilation is the way forward. So what are the checklists before proning and after proning? This is one of the best checklists that I could get from Faculty of Intensive Care Medicine. Even here, it is very clear, involve the patients when the PF ratio is less than 150. You need to have very good, nursing care for these patients. Okay, whenever you have this, uh, before this, confirm all the members, who are involved with the care should be available for helping. Make sure your tubes are secure, NG is secure, all the lines are secure. If chest tubes are present, they should be clamped. Optimize the hemodynamics, make sure the patient is sedated well, oral care, all the other routine care in the ICU should be completed. So once you finish this, and once you're ready to, prone this patient, you have the timeout. You should have adequate people who are present, maintain adequate sedation with, you can use either RAS or whatever scoring systems you're using. Adjust the ventilatory settings, make sure that you cushion all the pressure points properly. Okay, once you finish this, check for any possible disconnections, make sure all the things are okay, recheck your ventilator, okay, if things are okay or not. After this, you can sign out. Okay, so again, when you're signing out, make sure that you document all the positions of the tubes, so that if there is any change in the position, it can be easily recordable. Okay, so you can have a checklist like this where it involves a lot of P's. So there have been trials wherein they have put splints in the thoracic and pelvic region, and there have been studies where they have not put any splints, just made the patient lie prone position like this. Okay, so it depends on institute to institute. So where we use both the thoracic and the pelvic splint. Okay, so whenever we use this, all that you need to remember is you should have a reverse Trendelenburg of 30 degrees. Avoid any pressure source. Avoid any corneal ulcers. The eye should be taped. Make sure that adequate suctioning is available. Okay, all pressure points should be having some support. Pelvis, abdomen is supposed to be free, it should not be compressed. Okay, arms should be in neutral position. There have been studies where they have put it across the body, or you can even place them above. Okay, there shouldn't be any excessive stress or strain on the patient. Okay, so patients, if they are already on renal replacement therapy or multiple lines, make sure all these things are present and in a safer accessible position, so that you need not disturb the patient on prone ventilation. Always it is a good practice point to do a blood gas analysis after 30 minutes to 1 hour post proning, so that you know whether whatever you're doing is going in the right terms. What are the contraindications for proning? The absolute contraindication for proning is unstable spine fracture. Okay, if the patient has an open chest or post cardiac surgery, a trauma less than 4 hours, even this is supposed to be an absolute contraindication. If you have a patient on an ECMO cannula with biventricular assist device, which is a very, very rare phenomenon, even this is a absolute contraindication, because the patient would not be it will not be easy for us to prone this patient at all. Okay, so these, for the practical point of view, these are the absolute contraindications. The relative contraindications are hemodynamic instability, open abdominal wounds or bone fractures, or morbid obesity, late-term pregnancy, recent tracheostomy, ongoing seizures, raised ICP, or intraocular pressures, or severe facial fractures. So what is the evidence in ECMO and proning? I was telling you previously, there is contraindications for patients with BiVAD and ECMO, but if the patient is on a VV ECMO, still there have been, a there are 2 to 3 RCTs. One of the most common ones which have been shown is the prone ECMO. Prone ECMO has shown good results with patient on ECMO with prone. Okay, so the length of need for ECMO, hospitalization, and there is also a slight tilt towards improved mortality in such patients as well. Okay. So coming to awake proning, I think so this became vogue after COVID pandemic. So I'm going to use one of those protocols itself. So because we have seen so many benefits of prone ventilation, what they usually thought was, will it help in patients without a ventilatory support? And that is when we came to the attribution or application of a SPANK protocol in COVID patients. So whenever you have a patient with a pneumonia, probably viral or bacterial pneumonia requiring oxygen supports, you see usually the saturations are hovering around 92 to 96, requiring more than 5 liters of oxygen. Or if the PF ratio is less than 300 and a ROX index on HFNO is between 3.85 to 4.88, these are the patients who can be considered for awake proning. Okay, so if the patient is on more than 5 liters of oxygen for maintaining SATs between 92 to 96, if the patient is on HFNO and the ROX index is between 3.8 to 4.8, these are patients who can be recruited. But if you feel that the ROX index is less than 3.8, if the patient is actually having hemodynamic instability, PF ratio is very less, like less than 200, probably awake intubation would be relatively contraindicated, because we have to go by a case-to-case scenario. So once you have these parameters in situ, you can initiate the patient on awake proning. What usually is done is you can ask for 6 to 8 hours of proning per day and give them breaks. The SPANK protocol said that prone the patient for at least 3 to 8 hours per day, twice a day, allowing breaks for eating. And you should measure the ROX index between 2, 4, and 6 hours period. Wherever you see the ROX index dropping less than 3.8, stop it. Or if the patient's PF ratio less than 200, stop it. Okay, probably these patients are failing the awake proning. The target parameters which was seen in this is SpO2 of 92 to 96 and a ROX index of more than 4.88, or else the PF ratio increasing more than 300. Okay. So remember SPANK protocol, that is easy. You have good ROX index, minimal oxygen, usually 3 to 8 hours twice a day, and target all your respiratory parameters like SpO2, ROX index, and PF ratio. Improving, good. If they are not improving at the end of at least 8 hours or 6 hours, probably you can stop awake proning. Probably it's better to consider next modality, that is NIV or invasive ventilation. So what is the evidence of proning? So a lot of studies have been done for proning. So I have already said that in 1980s was a large first RCT case series came in. After the case series, the RCT started in 2001 by Gattinoni himself. Okay, both the studies, if you see, whenever the question, like I mentioned previously, that they have asked is evidence of prone ventilation, right? So when they ask a question about evidence of prone ventilation, you can usually write them in PICOT criteria. Okay, so PICO, population, intervention, control, and outcome. Okay, so whenever you have these things, please make sure that you write in such headings so that you will get the bare minimum marks if you don't know the details of each study. Okay, so these are the 5 studies which have usually been mentioned. These are the 5 RCTs. The last one is the ProSeva, the Guerin et al. NEJM 2013. Okay, so Gattinoni and Guerin have been doing trials on ARDS, from time immemorial. What they did is they initially in Gattinoni, if you see, the inclusion criteria was a PF ratio of less than 200 with 5 centimeter of PEEP, or less than 300 in 5 centimeter up to 10 centimeters of PEEP. The average PF ratio which they took into consideration was roughly around 130 to 160, 170. Okay, and the PEEP enrollment was between 10 to 13. The tidal volume which they delivered was actually higher. Okay, and they did not think about stabilizing criterias or anything like that. And the duration of prone which they did was only for 7 hours. So the number of prone days was roughly around 5 days. So what this trial did was, it did not show any mortality benefit. Okay, it also did not show any evidence towards reduction in length of stay. Okay, the only thing which was negative towards this is, if you see here, in 2001, there was no concept of lung protective ventilation. The ARMA was not being widely put in. So probably that is what one was the cause for a failed mortality benefit in Gattinoni's trial. So that is what is postulated. If you see 10.3, it's quite a large tidal volume. The average, which they say was around 650 in the study. Okay, that is one thing. Another thing is, when they did a subgroup analysis of this study, they found out that when the PF ratio was less than 150, and those patients benefited from that. Okay, so that gave Guerin some amount of understanding to do his study, but he did not understand the concept and he continued with the same thing. Even he didn't improve on his tidal volume. Even he didn't improve on his recruitment strategies. He also continued with a PF ratio of less than 300. So that is one of the reasons even he failed. The only difference between Gattinoni and Guerin was he just increased the duration of proning from 7 hours to 8 hours. So that again did not show any benefit. Even this also failed to prove any benefit. Mancebo's trial is the first landmark trial, if you want, if so as to speak, instead of us, telling that ProSeva was the one which gave us all the things. Mancebo actually had a good study. Here, if you can see, the average tidal volume is almost closer to the lung protective ventilation. He used the ARDS definition, okay, and then the recruitment when they did the PF ratios were less than 150. Okay, so these things proved benefit, and there was some amount of mortality reduction which was noticed. So if you can see 43% to 58%, which is actually significant. So this was the first trial, Mancebo et al. In 2006, which showed the evidence for prone ventilation. Okay, so Tacon et al. Also increased it. What we need to see here is, along with the PF ratio, the most important thing was the duration. Okay, the duration which Mancebo used was for 17 hours. Probably the recruitment strategy with lung protective ventilation, along with the duration of proning, helped to improve the mortality in such patients. Okay. Coming to Tacon et al., even he used 18 hours, but in this study, they couldn't find any difference in mortality very much. Okay, so this is one of the close to negative studies in proning. Okay, but again, they had used the similar parameters which Mancebo had used. So the only thing was the patient population size. If you see 142, this is the only advantage which he had. He increased the number of patients being recruited. Okay, but then came the landmark trial, that is the ProSeva trial, which involved PF ratios less than 150 with a PEEP of more than 5 with a FiO2 more than 60%. Okay, and they involved at least more than 16 hours of proning, and they found that that there was huge mortality benefit which was involved. So much so that the number needed to treat, can anyone say how much it was? Because everyone keeps asking that. The number needed to treat was around 6 to 7, if I'm not wrong. Okay, so that is one of the reasons it became a huge hit, and then it came into regular use. So these were all the RCTs which we had. So they were followed by multiple meta-analysis. The recent one being one in 2022, but I've just posted one at by Munshi et al, which is usually the one which is spoken about, because what they did here is they have done prone ventilation from 7 to 8, directly jumped to 17-16 hours. So there is no study done between them. So what they when they did a pooled analysis in meta-analysis evaluation, what they could find out is prone positioning is likely to reduce mortality among patients with severe ARDS for at least 12 hours of prone ventilation. So that was the minimal number of hours of proning which was required to get a mortality benefit, especially for a 28 day mortality. Okay, so this is the current evidence, and this is what you need to answer about. So use a Eccor format, use what was the inclusion criteria, exclusion criteria, talk about the ARMA ventilation, talk about the duration of ventilation. Okay, and then you have to talk about the inclusion criteria from Gattinoni, Guerin, Mancebo, and the Proseva, which was very clear, which also included the FiO2 and the PEEP values. Okay, so thank you. Any questions? Okay, I think so, Srihari, you can carry on.
Oh, okay, Darshan. I'll share my screen then.
Yeah.
Is my screen visible?
Yes, yes.
Okay. Okay. So my next talk is going to be on high flow nasal cannula, and I'll also be talking on ROX index. So questions in relation to HFNC was asked in DRNB formative assessment test in 2020. But it's also very important from a practical perspective, because in usually the afternoon OSCE stations, usually in equipments, usually the HFNC apparatus will be kept, and during that time they will ask you about related trials also. So it is important both from a theoretical and a practical perspective. So the main points I'll be discussing in relation to HFNC will be about the introduction, the components, the physiological effects of HFNC, the indications, about ROX index, and HFNC associated trials. Another important thing I want to emphasize is ROX index was asked as a theory question last year, that is in October 2023 in paper 2 in conjunction with Eccor score. So it is also important to know about it. So coming to the introduction, HFNC has been gaining attention as an alternative means for non-invasive ventilation for critically ill patients. This is what most of us know about, especially in those whom NIV intolerance is a big concern. So coming to the apparatus, it has 4 important components. One is the air O2 blender, that is here, that you can see in most of the machines that we keep at the bedside. Then it has a active heated humidifier which is present. Then a single heated circuit and a nasal cannula. So it delivers heated, that is between 32 degrees to 37 degrees, and humidified, that is up to 100% relative humidity of oxygen, with NaFiO2 between 21% to 100%, and at high flow rates of up to 60 liters per minute. So this is one of the main advantages and the benefits why HFNC is very commonly used in clinical practice. And the FiO2 and flow can be titrated independently based on the patient's requirement. So coming to the physiological effects of HFNC, the first one is about the humidification of oxygen. So
The problem is when you inhale cold and dry air, there is going to be dryness of the airway, and that is going to cause an impaired mucociliary functions. That is, it's going to impair secretion clearance and your airway defenses. Now, because of this, there is going to be an increase in your airway resistance, and that is going to lead to an increased work of breathing. Now, HFNC not only provides high flow, but also contains an active humidifier. That is, it provides a relative humidity of almost 100%. So it warms and humidifies the air before delivering it to the airways. And this humidified air loosens the thick secretions, improves the mucociliary functions, and improves the airway clearances. So this is very important. That's the first point, is in relation to the humidification of oxygen. The second one is in relation to reduction of anatomical dead space and increased carbon dioxide washout. So as most of you would be knowing what anatomical dead space is, just for completion's sake, it's the segments of the respiratory tract responsible for conducting air to the alveoli and respiratory bronchioles, and it does not take part in the gas exchange. So continuous flow of fresh air at high flows produces a more efficient ventilation by facilitating carbon dioxide clearance from the anatomical dead space, thereby reducing minute ventilation and the work of breathing. So this is another important perspective for the benefit of using HFNC. So one is about the humidification of oxygen, and the second one is about the reduction of anatomical dead space and increased CO2 washout. The next one is in control in the fraction of inspired oxygen. So this is mainly in comparison to our conventional O2 therapy devices, that's the face mask devices. So the inspiratory flow of a patient varies with each breath. So if the inspiratory flow is more than the supplementary oxygen flow that is being delivered by the conventional oxygen therapy devices like your face mask, then the remaining air that is recruited from the atmosphere into the O2 therapy devices, diluting the oxygen content of the air of the amount that is delivered to the patient. So ultimately, the FiO2 that is delivered is going to be low. This problem is circumvented with the use of HFNC because it provides high and constant flow and it overcomes the issue of gas dilution. So this FiO2 is more constant at higher flows and it can be maintained between an FiO2 0.21 to 1. The next benefit of it is generation of positive expiratory pressure and alveolar recruitment. So the high flow through the HFNC can provide a small positive pressure in the airways. So with the mouth closed during breathing and a maximum flow of 60 liters per minute, the pharyngeal pressure usually remains around 3 centimeters of water. So one, it helps in maintaining the patency of the upper airway, and also in the lower airway, it helps to shift the fluid in the alveolar from the alveolar space into the perivascular interstitial space. So it helps in increasing number of alveoli participating in ventilation, that is alveolar recruitment. And another important factor is it helps in improving patient comfort. As most of you would have seen, most of the patients on HFNC will be able to communicate and also eat. And also they often prefer HFNC to other forms of non-invasive positive pressure ventilation, that is like BiPAP and CPAP, because they don't have to wear the tight fitting mask, which can be uncomfortable and also it can be claustrophobic. And also compared to conventional oxygen therapy, it is better tolerated because it is providing warmed, humidified gases that do not dry the respiratory mucosa. And most patients find it comfortable using it for long periods. So during COVID, this was a really remarkable device for use. So there are 5 important factors in relation to the physiological effects. The first one is the humidification of oxygen. The second is the reduction of the anatomical dead space and increased carbon dioxide washout. The third is the control of FiO2 that is being delivered. The fourth is the generation of positive end expiratory pressure and alveolar recruitment. And the fifth is the improvement in the patient comfort. So this is just a graphical explanation of what I had just spoken. So it decreases the inspiratory effort, providing lung protection, increased patient comfort because of the humidification and the interface, improved mucociliary clearance, decreased air entrainment. So a higher FiO2 is delivered. It decreases the minute ventilation, thereby decreasing it decreases the respiratory rate. It increases the airway pressure via the PEEP effect, and it helps in increasing the CO2 washout by decreasing the dead space. So again, I'm emphasizing these 5 points because these 5 points is very commonly asked in your theory. So that's why I'm emphasizing its use again. So because of high flow, during the expiration, there is going to be a PEEP effect that occurs. There will be alveolar recruitment and dead space washout. And on the inspiratory part, the peak inspiratory flow coverage is there. There will not be any entrainment of air because of the high flows. So the high FiO2 will be supplied, and there will also be alveolar recruitment and redistribution of tidal volume. So this will be leading to an improvement of PaO2 and PaCO2, thereby decreasing the work of breathing. That causes a decrease in inspiratory effort and decreasing the minute ventilation. And because of use of humidification and heating, there will be more comfort and better compliance, and it will help to prevent microatelectasis because of the effects of drying of the airways. So the indications. So in which all patients do we really need to use HFNC? One is what we already know, hypoxemic respiratory failure. So during COVID, we were using this very commonly in patients with mild to moderate hypoxemic respiratory failure. Then in patients post-extubation and having mild hypoxemia, this can be used as a bridge in conjunction with NIV. In post-operative HFNC in high risk or obese patients following cardiac or thoracic surgeries are in the peri-intubation period, that is as a form of pre-oxygenation. So these are the 4 well-validated indications. In addition to this, it can also be used in do not intubate order scenarios during bronchoscopy or in acute respiratory failure in immunosuppressed patients, as similar in indications for NIV. So the one in the previous slide is what I'm emphasizing again. During acute hypoxemic respiratory failure, they've shown that there is similar rates of intubation compared with NIV and face mask, reduced risk of intubation in patients with moderate to severe hypoxemia, reduced ICU and 90-day mortality. This is based on the Florali trial, and it improved breathlessness following treatment initiation. The second important indication is prevention of post-extubation respiratory failure. That is in the low-risk patients, high flow therapy was superior to conventional oxygen, whereas in the high-risk patients, that is in the obese patients or post-cardiac surgery patients, either HFNC or NAV can be used because HFNC was non-inferior to NAV. And it aids in taking breaks from positive pressure ventilation, permitting oral intake like medications and nutrition and communication. And it is more comfortable than conventional oxygen therapy in the form of nasal cannula or face mask and NAV. And it aids in pre-oxygenation during airway procedures, that is pre-oxygenation prior to and during intubation. And it also improves oxygenation during bronchoscopy compared with conventional nasal cannula. So monitoring of patients on HFNC, we usually use the ROX index. So in relation to NAV, it is the Eccor score, and with relation to HFNC, it is the ROX index. The acronym ROX stands for respiratory rate and oxygenation. It primarily reflects the work of breathing. So ROX index is defined as the ratio of SpO2 to FiO2 in ratio to the respiratory rate. That is the SF is to respiratory rate. It was developed by Rocca et al. And it is primarily used to predict HFNC failure in patients with acute respiratory failure, but can also be used in non-invasive positive pressure ventilation patients, but it has only moderate accuracy. So there will be different times that can be misleading, that is if it is being used in patients on NIV, that is positive pressure ventilation. So the components, as I mentioned, it is consists of a SpO2, FaO2, and a respiratory rate. So interpretation. So the ROX index margin for the risk of HFNC failure. So there are certain cutoff values which needs to be memorized to identify patients who are likely to fail from the ROX index. So we take a certain time point, we assess the ROX score. So usually it is done at 2, 6, and 12 hours, and usually the ROX index is 2.8, 3.47, and 3.85. So if it is less than these values at these time points, it indicates that there is going to be a high chance that the patient is going to fail on HFNC, and there is a need for intubating the patient. And at these three time points, it has a very good positive predictive value, that is around 98 to 99%. But more than 12 hours of HFNC use, and if the ROX index is 4.88, as that is the margin of cutoff is taken at that point, the positive prediction value is only 80%. But it does not mean that it's going to be a very poor marker. It still has a good validity. So in HFNO patients, ROX index was found to be superior to Eccor score. But the limitations was the ROX index was developed and mainly studied and validated in ARDS patients with type 1 respiratory failure. A key feature is the accuracy of the ROX index is avoiding hyperoxemia, because if you're going to keep a higher FiO2 and the saturation shows as 100%, your ROX index value is going to be very misleading. So that itself can cause many interpretation issues. So they usually ask to keep the FiO2 at the lowest at which the saturation is maintaining at 94. They usually say not to go more than that. And another important problem is predicting probability of intubation is not limited to respiratory parameters alone, because neurological and hemodynamic factors also play a role. So a patient who has an exclusive respiratory problem alone, ROX index can be a good marker, but patients who have associated other organ issues like CNS issues and hemodynamic issues, those factors also need to be taken into consideration when you're assessing for HFNC failure. So this is what I previously mentioned. So ROX index is SpO2 by FaO2 by RR. So you assess at 2 hours, 6 hours, and 12 hours. And if the score is less than 2.85 at 2 hours, you intubate. 3.47 at 6 hours, you intubate. And 3.85 at 12 hours, you intubate. So again, the magic numbers are 2.85, 3.47, and 3.85. So these are the cutoff points where you will have to consider for intubation. So are there any modified scores other than the ROX? Yes, there are. There is something called the ROX HR index. That is the ratio of the ROX index to the heart rate. And they've shown that if the value is more than 8, that is calculated as 6 and 10 hours after initiating HFNO, it actually outperformed the ROX index in predicting HFNO success. So for ROX HR, the cutoff value is at 8. And for ROX, you assess at 2, 6, and 12. And the cutoff is 2.85, 3.47, and 3.85. So with respect to the HFNC associated trials, I'll be concentrating on 3 trials. The one is the pre-oxyflow trial. Here, the main clinical question that they had asked was, does HFNC improve the efficiency of pre-oxygenation before intubation compared with the high fraction inspired O2 face mask, that is like a NRBM mask? In conclusion, they had actually found that HFNC as a pre-oxygenation device did not reduce the lowest level of desaturation. So it was found to be effective. The next one was one of the popular trials, that is the FLORALI trial, that is high flow oxygen through a nasal cannula in acute hypoxemic respiratory failure. So in that, the clinical question was, in patients with acute hypoxemic respiratory failure, does HFNC compared with standard O2 delivered through a face mask or NIV prevent intubation? In conclusion, they found out that in acute hypox respiratory failure, and without hypercapnia. Hypercapnia, mind you, the term was very important. Without hypercapnia, treatment with HFNC standard face mask or NIV did not result in a significant difference in intubation rates. But there was a significant difference in favor of HFNC in reducing 90-day mortality. So that was one of the main reasons why HFNC started to take a lot of priority in regular practice. The next is the OPERA trial, that is the effect of early post-extubation high-flow nasal cannula versus conventional O2 therapy on hypoxemia in patients after major abdominal surgery. So the clinical question was, in patients who have undergone major abdominal surgery, there's application of HFNC compared with standard O2 therapy decrease the incidence of hypoxemia at 1 hour after intubation. So the conclusion was, among patients undergoing major abdominal surgery and receiving intraoperative lung protective ventilation, preventive application of HFNC after extubation compared to standard O2 therapy did not result in a significant reduction in incidence of postoperative hypoxemia. So the routine use of postoperative HFNC after extubation didn't seem to be justified in similar subset of patients. In 2024, there was one trial that had come out studying the use of HFNC in patients with acute exacerbation of COPD. That is, during the last year when we were actually planning for preparing for our exams, they were actually saying HFNC as a modality can be used in patients with ACOPD, that is in mild to moderate diseases. The good thing that this trial had come out and it has shown that it is going to be very harmful if you use HFNC in these subset of patients. So they have taken patients with ASCVD with a baseline arterial blood gas between 7.25 and 7.35 and PCO2 more than 50. And the main primary endpoint was to assess the rate of treatment failure, that is need for endotracheal intubation, and secondary endpoint was mortality, that is either at 12 or 48 hours or 28 days plus ICU and hospital length of stay. So as I said, in ASCVD patients with moderate hypercapnic respiratory failure, HFNC was not shown to be non-inferior to NIV and resulted in higher incidence of treatment failure than NIV when used as the initial respiratory support. So in ACOPD patients, as before and will always be, NIV is the number one. HFNC does not have a role over there. So just for revision, I'll just go through the physiological aspects of it since it is very important. So the main parts of physiological effects of HFNC are: one, it helps in humidification of oxygen. It helps in reduction of anatomical dead space and increase carbon dioxide washout. It helps in control of fraction of inspired oxygen. It helps in generation of positive expiratory pressure and it aids in alveolar recruitment, and it helps in improvement in patient comfort. So this was the main things I wanted to emphasize. And its main uses are in hypoxemic respiratory failure, in post-extubation patients, and during pre-oxygenation, and in high-risk patients or obese patients following cardiac or thoracic surgery. And the important thing about ROX is the time point and the cutoff needs to be known. As I said, at 2, 6, and 12 hours, you have to assess, and the cutoffs are 2.85, 3.47, and 3.85. So, and the three trials that you need to know about are the pre-oxyflow trial, the Flow-Rally trial, the Opera trial, and the 2024, the latest trial in relation to ACOPD had shown that HFNC is not a good modality to initiate respiratory support in these subset of patients. Thank you. So this is the first talk that I finished. The next will be on Eccor. So if anyone has any queries in relation to HFNC, please do let me know. Anyone? Okay, so then I'll go into Eccor. Is the slide visible?
Yes, sir. Visible, sir.
Okay, thank you. Okay, just a minute. Okay, so next is about extracorporeal carbon dioxide removal. I think over the last one day, they've spoken a lot about VV ECMO as a modality of treatment in hypoxemic respiratory failure. And from an exam perspective also, VV ECMO related questions have been asked, especially the Cesar and the Eolia trials, the critical appraisal related to that. But over the last few years, Eccor has been studied in various centers over the world. The problem is there have not been any very convincing evidence for its use in regular practice. And also from our academic standpoint, there have not been a lot of questions that have been asked so far. So the problem is in the subsequent years, there is a potential that this question will be asked. So it is important to know about it. So I mentioned the points from an exam perspective so that it will be easy to remember. So under Eccor, I'll be discussing about the introduction, the physiology, the clinical applications, contraindications, the technical aspects, the supportive care, complications, weaning, and the related trials. Related trials meaning there are two important trials that were published, and those are the ones I will be emphasizing on. So coming to the introduction, extracorporeal carbon dioxide removal, that is Eccor, is an advanced form of life support that is mostly used in patients with severe hypercapnic respiratory failure without hypoxia. So Eccor is like ECMO, but it uses lower blood flow, that is usually less than 2 liters per minute. So this technique has very little or it has no impact on blood oxygenation, unlike ECMO, where they use actually 3 to 7 liters per minute flows to enable both oxygenation and carbon dioxide removal. So coming to the physiology of it, the use of Eccor in hypercapnic failure, it actually allows a decrease in your respiratory dive. It reduces the respiratory rate and allows for increasing your respiratory time on your mechanical ventilation settings. So in that way, it helps to reduce your dynamic hyperinflation and it also helps to reduce your muscle fatigue. So in one way, it helps in increasing your CO2 elimination and it helps in reducing your CO2 production, ultimately leading to correction of respiratory acidosis. And also because there is a decrease in the there's a decrease in your dynamic hyperinflation, the stress on your pulmonary vessels is also reduced, and that helps in improving the right heart function also. So this is one among the main reasons why Eccor is shown to be very beneficial in patients with an hypercapnic respiratory failure, that is in patients with an acute exacerbation of COPD or a status asthmaticus. In ARDS patients, once you start on Eccor, you can reduce the tidal volume to less than 6 ml per kg, thereby reducing the plateau pressures, the driving pressure, the mechanical power, while maintaining the pH and the PaCO2. So the main clinical applications in relation to Eccor was in patients with status asthmaticus. They've shown that as the most common application because in these subset of patients, usually the oxygenation is not much of a problem, but it is more related to the ventilation. So when they go into respiratory fatigue, that time they can go into severe uncompensated respiratory acidosis, that the pH can go less than 7.2. And or there can also be evidence of excessive dynamic hyperinflation despite optimization of medical therapy, that is despite maximum medical therapy. But as I said earlier, if at all oxygenation is also compromised, then you will have to push it on to VV ECMO, which is most preferred. The other indications where it can be used is in end-stage lung disease as a bridge to lung transplant, that is in patients with an acute and chronic hypercapnic failure, in acute exacerbations of COPD to facilitate weaning or to avoid mechanical ventilation, and in patients with moderate to severe ARDS. So these are the four important indications. In that, status asthmaticus and acute exacerbations of COPD are the high priority. Because the easiest way to remove it is, Eccor is to remove carbon dioxide, and the diseases in relation to carbon dioxide are asthma and COPD. So exacerbation of these conditions are where it's going to be most helpful in it. The other conditions where it can be used is, like I mentioned, in end-stage lung disease as a bridge and in moderate to severe ARDS. The benefit of its use, as I had mentioned previously, reducing the total tidal volume, thereby reducing the stress, that is by decreasing the driving pressure and the plateau pressure. So it decreases the stress on the lung alveoli. So the contraindications is almost similar to VA or VV ECMO. So the absolute contraindication is severe irreversible non-cardiac organ failure or any condition limiting survival, that is severe anoxic brain injury, or there is no transition to a well-defined endpoint, that is recovery or transplantation, or patients with severe aortic insufficiency or aortic dissection. Whereas a relative contraindications are severe coagulopathy or a contraindication to anticoagulation, severe immunocompromised status, that is a prolonged duration of mechanical ventilation more than 7 days, lack of resources to support ECMO associated care, or patients with advanced stage. So for ease of understanding, I've just put 4 to 5 points in the contraindication so that it's easy to memorize. These same contraindications can also be used in VV ECMO, and it can also be used in VA ECMO if at all it is being asked. So coming to the technical aspects, the first thing is about the configurations of Eccor. So one is the one we use commonly in VV or VA. You have two sites of cannulation. One will be through the drainage, that is the drainage will be through the femoral, and the return cannula will be through the IJV. So here you can see the drainage cannula through the femoral, it goes through the pump, the control center will be there, and there will be an oxygenator, that's the circuitry device will be there, and from there it will return back to the patient. There is also one type where there is a single site veno-venous extracorporeal membrane oxygenation. That is, this is almost like a HT catheter that will be inserted. And the most common site is the right IJV. So one cannula will be used as a drainage and one port will be used as a return. So this is also one of the modalities that can be used. And the last one is the AV Eccor, that is the pumpless arteriovenous bypass. That is, the drainage is from the femoral artery, that is through the arterial blood, and the return is in the femoral vein with the decarboxylated blood. So the blood flows from the femoral artery to the contralateral femoral vein, creating a pumpless arteriovenous bypass equipped with an artificial gas exchanger across the AV shunt, that is between the arterial to the venous flow. So this allows the sweep gas to remove CO2, but there are certain caveats. The important thing is this pumpless system requires a arteriovenous pressure gradient of more than 60 millimeters of mercury and a cardiac index more than 3 liters per minute per meter square, which is very much unsuitable for hemodynamically unstable patients. So as I mentioned, the three configurations is there. One is one similar to the one used in VV ECMO, where you have a separate drainage and a separate return cannula site. There is one, the dual lumen, almost like one which is used as a HT catheter, And last one is a AV Eccor, where a femoral artery and femoral vein is separately cannulated and it produces a pumpless system, but the gradient between the artery and the vein should be more than 60 mm of mercury and the cardiac index should be more than 3. So next is about the catheter insertion, where oxygenation in ECMO is largely dependent on the circuit blood flow rate. The higher the circuit flow, the better the oxygenation. CO2 removal is primarily determined by the sweep gas flow due to the efficiency with which carbon dioxide transfer occurs across the brain membrane. The important is there is a lot of physiological aspects related to this. I will not be able to discuss it here, but they say that carbon dioxide having a better diffusibility, usually the sweep gas flow is sufficient for its removal. Therefore, the Eccor can be achieved with lower blood flow rates and correspondingly smaller cannulae. Usually 15 to 19 French is usually used than what is required for oxygenation during ECMO. For ECMO, they go between 17 to 26 French. That is, I am including both the drainage and the return cannula. However, if there is an anticipated need for extracorporeal oxygenation, larger cannula to support ECMO can be placed should it be needed at some point during the patient's illness. Even though it is easy to say it theoretically, during real-time events, it is not very feasible. It's not easy to remove a cannula and insert it. So in such cases, if patients are going to have an anticipated hypoxemia along with hyperventilation, it's always better to go with the VV ECMO. As I said, in patients with status asthmaticus and an ASCOPD with difficult weaning or to avoid intubation would be the ideal choice for patients in whom Eccor can be considered. So this is the Eccor circuit. So as I said, there will be a drainage cannula which will pass through a pump, enter into the ECMO chamber, and there will be a sweep gas flow which will be there, which we can adjust the flow rates to aid in removal of carbon dioxide. And once the gas exchange has occurred through the return cannula, it will go back to the patient. So the initial settings and titration. Following cannulation, the patient is immediately connected to the Eccor circuit, that is typically the pump, the membrane lung, and the monitor, and the sweep gas, that is a blend of oxygen and air, the fractions of which are determined by the provider and set through a blender, and it is connected to a membrane lung. There are new universally agreed upon settings. So from a theoretical aspect, that is from exam preparation, this is a very good point for us. So as an estimate, the following are achieved incrementally over the first few minutes after initiation. The pump speed to achieve a extracorporeal blood flow appropriate to the pump. That is, usually we start it at low rates, that is between 0.4 liters per minute, and we can go till a maximum of 3 liters per minute based on the cannula that is used. A larger cannula, higher flows will be well tolerated. Sweep gas flow, that is typically ranging between 1 to 10 liters per minute. But the important thing is patients with an underlying neurological disease or patients with chronic respiratory failure, the rate of reduction of PCO2 has to be very gradual or it can have deleterious effects. And initially the FiO2 is set at 1 and it is gradually tapered. So as I mentioned previously, for those with marked uncompensated respiratory acidosis, the sweep gas should be gradually increased over several hours to avoid complications associated with the rapid changes in PSO2 like intracerebral hemorrhage. So we spoke about the configuration settings, that is the configurations, then the catheter insertion, then the initiation settings. So this covers the main crux of the Eccor. So the next is about supportive care. So in relation to mechanical ventilation, we need to reduce the minute ventilation, that is the tidal volume and respiratory rate, and prolong the expiratory time, especially in cases of acute exacerbation of COPD and asthma. because once the Eccor is initiated, that will take care of the carbon dioxide removal. So these factors can then be adjusted to help in improving the resistance. And subsequently, we can discontinue the neuromuscular agents and minimize the use of sedatives to facilitate early extubation. And circuit management and monitoring is, as I said, similar to what we do during VV ECMO or VA ECMO. That is, complete blood count should be done regularly. Assess for hemolysis, that is LDH, total and indirect bilirubin, systemic arterial blood gases, coagulation studies as per institutional protocol. Because some institutes check the ACT, some check the APTT. So it varies according to institutes, and the frequency of checking also varies. So as per institution protocols, it needs to be followed. And chest radiographs needs to be assessed regularly. And ECMO circuit related pre and post membrane pressures and blood gases also need to be checked. And importantly, the cannulation site should be always checked for bleeding or any signs of infection. And if the cannula are being placed in the foot, then the distal perfusion must also be assessed for. So coming to the complications, you can assess it divided into patient-related complications, which are anticoagulant-related bleeding, hemolysis, heparin-induced thrombocytopenia, and recirculation. Then you have catheter-related complications, that is catheter site bleeding, catheter malposition, displacement, catheter kinking, vascular catheter infections, vascular occlusions, thrombosis, hematoma, aneurysm. And device-related complications like pump failure, oxygenator failure, clot formation, air embolism, and heat exchange malformation. Now, just a simple tip for all the candidates. Patient-related complications and catheter-related complications invariably will be similar in almost every extracorporeal therapy. It is only the device-related complications which will be specific for that type, and this set of complications are going to be similar even for VA and VV. So if you remember this set of complications, you can actually use it for interchangeably for the other extracorporeal therapies also. But I don't want to say it for device-related complications because that is specifically only for ECMO. So next is coming to the weaning. So once the underlying disease process has sufficiently improved and it is assessed that the patient is adequately supported with conventional mechanical ventilation, weaning from ECMO can be done. I think I think everyone would have understood. Once the underlying process has settled, the disease process has settled, the patient is adequately supported on conventional mechanical ventilation alone itself, then Eccor can be weaned from. So how you proceed is the main factor that you need to use in Eccor is the sweep gas flow. So you try to reduce the sweep gas flow to a very low level and you liberalize your ventilator settings. So once you finish all of that, then you turn off the sweep gas flow. That is, it's also called an off sweep challenge for 30 minutes and obtain an ABG. So the target for oxygenation and ventilation are for oxygenation, you need to have with an FiO2 of FiO2 less than 60% and a PEEP of less than 10, you need to have a PO2 more than 60. Whereas for ventilation, you need to have a pH more than 7.35 while being able to maintain a tidal volume of 6 or less ml per kg of predicted body weight with a plateau pressure less than 30 and a respiratory rate less than 28 without any evidence of increased work of breathing. This is one of the most easiest ways I could put it. And if the conditions are satisfied, then you can proceed for decannulation. And the important thing is you need to stop anticoagulation 1 to 2 hours prior to decannulation, because once the patient satisfies the off sweep challenge, we are going to decannulate. So at that time, if anticoagulation has not been stopped, there is going to be very severe bleeding from the cannulation removal sites. So it needs to be taken seriously and it should be always kept in mind. So important trials related to Eccor. One is the supernova study that came in 2019. So the main clinical question was, can extracorporeal carbon dioxide removal safely facilitate ultra-low tidal volume ventilation in patients with moderate acute respiratory distress syndrome? Ultra-low tidal volume meaning tidal volume of 3 ml per kg. So the conclusion, they had shown that Eccor can facilitate ultra-low tidal volume ventilation. So as I mentioned in the pathophysiology, by reducing the tidal volume, you reduce the shear stress and strain, and you help in lung recovery. But that being a positive trial, then subsequently the rest trial came. In mechanically ventilated patients with acute hypoxemic respiratory failure, does lowering tidal volume using extracorporeal carbon dioxide removal compared with conventional low tidal volume ventilation improve all day 90-day all-cause mortality? So the conclusion was it did not. It did not result in a reduction in mortality at 90 days. So the supernova study showed that ultra low tidal volume technique can be used in Eccor safely. That was a positive trial, but in rest trial, they'd shown that it does not help in reducing mortality. That is despite of adjusting the ventilator settings. So this is very important to know. There are other trials that had come, but all those trials are not landmark trials. They have studied it. Some have shown that they are beneficial in patients with status asthmaticus and patients with ASCOPD as a uh, modality that can be used during weaning or to avoid intubation. So those are the main subset of patients in whom majority of the trials related to Eccor were done. So just for completion, I just want to emphasize on certain things. So introduction, as I told, mainly Eccor should be used as a modality in patients with hypercapnic failure with no hypoxemia or minimal hypoxemia. If you feel that the oxygenation is going to be worsening or the trend of the disease in relation to oxygenation and ventilation is going to go back, then VV ECMO would be a better option, provided there has been an adequate optimization of therapy that has been already done. That is optimization of medical therapy. With relation to the physiology, I told that once you use Eccor, you can reduce the minute ventilation. That helps in reducing the stress and strain on the heart, on the lungs. That helps in improving outcomes. So the clinical applications, as I had emphasized, is status asthmaticus, acute exacerbation of COPD, that is as a marker during modality during weaning or to avoid intubation. The other two where it can be used is as a bridge to transplantation in acute and chronic respiratory failure and in patients with moderate to severe ARDS, but it has not been shown to be very helpful. Then the contraindications, as I said, there are absolute and relative that I've discussed. And the technical aspects, you have configuration, you have two cannula system, then you have a single cannula with two ports, and you have a AV Eccor, that is a pumpless system. But for the pumpless system, you need a pressure gradient between the artery and vein of 60 mm of mercury and a cardiac index of more than 3 liters per minute of meter square. Then for the cannulas, ideally you can go with 15 to 19, but as they say, if at all there is a worsening of oxygenation and there is a need of VV ECMO, it's preferable to go with larger size cannulas. And initial supportive care, initial settings that you need to keep are, we have to start the pump speed as low as 0.4 and progressively increase it. The sweep gas has to be very low, it is between 1, and then progressively increase it. And in patients with already chronic respiratory failure and patients with the CNS disorders, it needs to be controlled very slowly because it can lead to neuro-related complications. And FiO2 in the beginning should be set at 1 and reduced gradually. And complications, as I said, it can be classified as patient-related, catheter-related, and device-related. And weaning, you need to come down on the sweep gas to at least 1 liter. Then you stop the sweep gas, assess for 30 minutes, take an ABG, assess the oxygenation. in the ABG, if the PaO2 is more than 60 with an FiO2 less than 60% and a PEEP less than 10, and the ventilation is with a pH more than 7.35, with a tidal volume of at least 6 ml per kg, predicted body weight, plateau pressure less than 30, respiratory rate less than 28, with adequate no accessory muscle use, then you can go ahead with decannulation. And the important trials are the supernova trial and the rest trial. The supernova is a positive trial and the rest trial is a negative trial. This is about Eccor. So if any queries are there, please do mention in the chat box, or if there is, if you want to discuss it later, you can put it up in WhatsApp. So I'll then go on to the next topic. Is the screen visible? Is the screen visible now?
Yes, sir, visible.
Okay, so just a second. So the next talk for discussion is on tension pneumothorax. Again, the questions related to tension pneumothorax over the last 4 to 5 years from theory perspective was less. It was more in the FMB papers before 2017 and more in the DM papers. But tension pneumothorax has very important implications from practical exam perspective, because in radiology station, pictures will be definitely kept and questions related to management will also be asked. So it is important to know about it, and it's also important to know about it because we anticipate these problems very commonly in ICU. So related to tension pneumothorax, I'll be discussing about the introduction, classification, the etiology, the pathogenesis, clinical evaluation, diagnosis, treatment, and differentials. So coming to an introduction, it's most of what we already know. I'm just going in a brush up. I'm going to brush up, and the slides are very much concise and precise from an exam perspective. So that is one thing I want to emphasize here. So coming to the introduction, pneumothorax is a collapse of lung when air accumulates between the parietal and visceral pleura within the chest. Air is outside the lung but inside the thoracic cavity. This places pressure on the lung, leading to collapse plus shift of the surrounding structures. So you can classify pneumothorax as simple or a tension. In simple, there is no shift of mediastinal structures, whereas in tension, there will be a shift of mediastinal structures. So coming to the etiology, you can classify it as traumatic or atraumatic and miscellaneous. Under traumatic, you can classify it as penetrating or blunt trauma, which is commonly associated with rib fractures, and iatrogenic, most likely because of central line insertion, lung biopsy, percutaneous tracheostomy, pacemaker insertion, bronchoscopy, CPR, and following intercostal nerve blocks. Whereas in atraumatic causes, you have primary and secondary. In primary, there are no causes which can be attributed, but there are certain risk factors like cigarette smoking, cannabis, and cocaine use. Genetic predisposition is there, like alpha-1 antitrypsin deficiency, Marfan syndrome. Increased valsalva maneuver has during diving or military flying. Or they can be secondary causes, that is, patients with already underlying lung disease like COPD, lung malignancy, necrotizing lung infections like pneumocystis, TB, streptococcus, staphylococcus, Klebsiella, or Pseudomonas. And there can be miscellaneous causes that can be related to anorexia, catamenial, or exercise. The important thing is all of the causes that I mentioned can lead to tension pneumothorax. So it is important to know about it. The most common causes of tension pneumothorax that we anticipate in ICU is mostly traumatic. So coming to the pathogenesis, under normal circumstances, the pleural cavity pressure or the intrapleural pressure is negative as compared to the lung pressure and the atmospheric pressure. There is a tendency of the lung to recoil inward and the chest to recoil outward. The pressure gradient that is developed in the pleural space prevents the lung from collapsing. So this was the basic physiological concepts that we know about. So the pleural pressure, as you can see here, is on the negative side. So this prevents the alveoli from collapsing. But when a pneumothorax occurs, this intrapleural space gets accumulated with air. So the pressure changes from being negative to becoming positive. So when that occurs, that ability of the pleura to keep the alveoli is lost, and that leads to alveolar collapse. So during a pneumothorax, a communication develops between the pleural space and lung, resulting in movement of air from the lung into the pleural space. This nullifies the pressure gradient that is usually present, leading to a progressive rise in intrapleural pressure. Air accumulates in the pleural cavity through the disrupted pleura, but is unable to exit like a one-way valve, leading to increased intrathoracic pressure in the affected site. So the increase in intrathoracic pressure on the affected site leads to compression of the lung, decreasing its volume that causes collapse. So the affected lung is unable to perform its function at normal capacity. This leads to a decrease in gas exchange, leading to hypoxia. So this hypoxemia causes stimulation of the hypoxic pulmonary vasoconstriction, which leads to an increase in the pulmonary vascular resistance, worsening hypoxemia further and reducing the cardiac output. Whereas on the other side, other side is like it causes compression of the mediastinum, pushing it to the contralateral side. So it compresses the heart and the great vessels, reducing the preload and the cardiac filling pressures. So this leads to a decrease in cardiac output, and ultimately it can lead on to cardiac arrest if it is not treated in a timely manner. So this is an image of what I had just spoken. So when the pneumothorax becomes so severe, it causes a shift of the mediastinal structures. It becomes a tension pneumothorax. So coming to the clinical evaluation, the history point of view, usually it's a sudden onset breathlessness that can be ranging from mild to severe. There can be unilateral pleuritic chest pain, and it is important to look for risk factors and genetic predisposition. So that is mainly in patients with primary pneumothorax, in those whom we don't have a clear-cut cause, but they have developed a pneumo. As I told, the risk factors are cigarette smoking, cannabis use, and patients with morphins or alpha-1 antitrypsin deficiencies. So in physical examination, the exam findings in mild cases are usually not significant. We don't usually pick up anything, but in severe cases, there can be enlarged hemithorax on the affected side, diminished breath sounds, absent tactile or vocal phrenitis, and hyperresonant on percussion. If there is hemodynamic compromise, that is there is low blood pressure, the peripheries are getting cold, then that is a ominous sign. So diagnosis based on the bedside test that can we do, that the ABG, it can show hypoxemia and respiratory alkalosis that is due to a well-functioning contralateral lung. But when respiratory acidosis sets in, it is again a bad sign that shows patient fatigue. And if metabolic acidosis is also there, it is mostly associated with hyperlactatemia, and it's because of diminished cardiac output. ECG is usually non-specific. Mostly it shows only sinus tachycardia. But if there is already a previous COPD lung picture present, then there will be a right bundle branch block, plus or minus, and RV strain may be seen. Chest X-ray is not usually done in unstable cases due to logistic issues, because in most cases, the patient will be very sick. And in most centers, when we order for a chest X-ray, it takes at least 15 to 30 minutes. So at that time, the patient may deteriorate further. So if at all it is done, the important thing to note is about the effect of position. Usually air moves to the least dependent portion of the lung, and thus the radiographical appearance of pneumothorax occurs. Depends on the patient's position. The most common one that we anticipate in the ICU is in the supine position, that is mostly in mechanical ventilated patients. The pleural gas accumulates anterior in a subpulmonic fashion. So this leads to the typical deep sulcus sign, where the gas outlines the Hfnc sulcus. As you can see, in a subpulmonic fashion, it accumulates in the Hfnc sulcus, thereby forming this deep sulcus sign. And other signs that can be present can be subcutaneous emphysema can be there. There can be tracheal deviation to the opposite side in tension cases. And in patients with a pneumomediastinum, there can be a continuous diaphragm sign, which can also be evident, where both the leaflets of the diaphragm can be seen as one. So here you can see subcutaneous emphysema also being present here. And here is the continuous diaphragm sign. Here, because of pneumomediastinum also being present, it is present as a single structure. So in most of the exams, on the practical perspective, they usually ask, they keep an X-ray of a pneumothorax, and they often ask, how do you calculate the size of it? So based on the British Thoracic Society guidelines, they say the distance from the chest wall to the visceral pleural line at the level of the hilum is calculated. And if it is less than 2 centimeters, it is small. And if it is more than 2 centimeters, it is large. So if it is large, it roughly correlates to the pneumothorax occupying 50% of the thoracic cavity. So this is another image that I taken from UpToDate. This is a more accurate measurement of the size of a pneumothorax, where you go with A, B, and C. So A is the distance between the apex to the visceral line. Then B is at this point at the horizontal, any upper horizontal point, and the C is at the lower horizontal point. So based on this, the averages are calculated, and the percentage can be calculated, which is present as a graph. So based on the size of this pneumothorax in centimeters, it can give a small correlation about the size of the pneumothorax. So the most important diagnostic modality currently is the pleural ultrasonography. So usually they say if absent lung slide is there, then it becomes indicator of pneumo. It is not so, because in collapse also there can be absence of lung slide. So you need to look at 4 important points. That is the absent lung slide, absent B lines, absent lung pulse, and the presence of a lung point. If all of these are present, then you can very confidently say there is a pneumothorax because it has a sensitivity of 100%. CT scan is not done in cases of tension pneumothorax, as I said, because of logistic issues. So this is just an image of the lung point. Here you can see there is a normal lung which is sliding, and here is the part where the pneumothorax has occurred. So this point is called the lung point, where there is a distinction between the normal lung and the lung where pneumothorax is present. And here you can see the normal lung sliding which is present. This, I think many of you would have though most of you do ultrasounds regularly, so this is one of the findings you commonly see. And here you can see the presence of B lines. Here you can see B lines that are present. Now, just a simple tip for most of the candidates: if B lines are present, it excludes pneumothorax, because for B lines to occur, the pleural space should be devoid of air. If air is present between the parietal and the visceral pleura, it will not be able to reflect the lung congestion points. Thereby, the B lines will not be visible. And another thing is to assess for lung pulse. It refers to the sonographic finding of apparent oscillations of the pleural line occurring secondary to transmitted vibrations from cardiac contractile activity. So this should also be absent. So if lungs are absence of lung slide, absence of lung pulse, and presence of lung point with absent B lines. If all these are present, then it confirms the presence of a pneumothorax. So treatment, the first thing is ABC. It always needs to be stabilized. And if the patient is hemodynamically unstable, you go first with the needle decompression, and second, you will have to go with the intercostal drain insertion. So the place where you need to do the needle decompression is at the second intercostal space at the midclavicular line. So following this, a chest drain is placed. And the chest drain placement can be done either by a Seldinger technique or via dissection. Whereas if the patient is not hemodynamically unstable, but you have found out that the patient is becoming hypoxemic and there are chest X-ray findings suggest of pneumothorax, you don't need to go with the needle decompression. You can directly go for an ICD insertion. So why is the needle decompression important? Because it helps to convert a tension pneumothorax into a simple pneumothorax. The current evidence supports placing a large over the needle catheter over the fifth intercostal space, slightly anterior to the mid-axillary line. This is contrary to the previous landmark where they used to say at the second intercostal space, just below at the level of the mid-clavicular line. The new one is, as I said, fifth intercostal space, slightly anterior to the mid-axillary line is where the needle should be placed for decompression. There may be scenarios where you may anticipate obese patients, or there would be a lot of subcutaneous air present, thereby it can interfere with your needle decompression. In those scenarios, finger decompression can be done. That is, due to the variability of thickness of the chest wall, kinking of the catheter, or other technical or anatomical complications, needle decompression may not be successful. In this case, finger thoracostomy is an alternative approach. So needle decompression can be done or finger decompression can be done. As you can see, being a newer mode of location is to go with the fifth intercostal space just slightly anterior to the mid-axillary line. So this is almost the area where they're covering it. This is where now they say to go with the needle compression or the needle decompression or the finger decompression. So selection of tubes for majority of patients, that is stable cases due to spontaneous or hydrogenic etiology, 8 to 14 French is sufficient, but not if the patient has features of a tension pneumothorax. For patients on mechanical ventilation or tension pneumothorax, you need to go with larger thoracostomy tubes, that is preferably 24 to 28 French, due to the risk of bronchopleural fistula. So the main rationale why they usually select these tubes is based on the Hagen-Poiseuille equation. This is just for, I've just added this slide just from an academic standpoint. So the important thing is, do you routinely use a negative pressure suctioning? No, you don't use it. There is no evidence to suggest its benefit. And the placement is, any pneumothorax is best treated with a chest tube placed in the fifth intercostal space, just anterior to the mid-axillary line. So this is the triangle of safety. So the base is at the fifth intercostal space. The apex is at the base of the axilla. Anterior is the lateral edge of the pectoralis major, and posterior is the lateral edge of the latissimus dorsi. This anatomical based topic, that is like the triangle of safety, was asked recently in the theory exams. So it is important to know about it. So the important differentials in relation to chest pain and dyspnea other than pneumothorax are pulmonary embolism, acute coronary syndrome, pneumonia, pericarditis, rib fractures, esophageal spasm, and acute costochondritis. Thank you. So as I said, the important things to look into are introduction. As I said, pneumothorax can be simple or it can be tension. Tension means there will be shift of the mediastinal structures. Classification can be traumatic, atraumatic, or miscellaneous. Traumatic can be because of blunt or penetrating injury or iatrogenic, and atraumatic can be primary or secondary. Primary, where there are no cause evaluated, you go based on risk factors, and secondary, most likely because of COPD, malignancies, or pneumonias with cavitations or necrotizing kind of pneumonias. And miscellaneous can be in cases of anorexia or catamenial. And pathogenesis, as I told, there will be both hypoxia because of collapse of the lung, and there will also be hemodynamic compromise because of compression of the mediastinum, thereby compressing the great vessels and the heart, thereby decreasing the preload and the afterload. And clinical evaluation, in mild cases, there's nothing much that can be seen, but in severe cases, there will be hemodynamic alterations. There can be hypoxemia, there can be increased work of breathing, and there can be the hemithorax can be enlarged on the side of the pneumothorax if it is very severe. Subcutaneous emphysema can also be there. Diagnosis, you can go with either chest X-ray if it is available early. You need to look for the deep sulcus sign, and you can also assess for presence of pushing of the trachea to the opposite side. But it is also important to quantify the severity of pneumothorax from a practical exam perspective. And for ultrasound assessment, you need to have 4 important signs. That is absence of lung slide, no B lines, no lung pulse, and presence of lung point. CT is not indicated. Regarding to the treatment, if hemodynamic instability is there, you need to do a needle decompression first. You need to do it at the 5th intercostal space, just anterior to the anterior axillary line. And if at all there is difficulty in locating the site, you can go with the finger decompression. And the next thing is to go with an ICD insertion. Whereas if the patient is stable hemodynamically, you can go directly with the ICD insertion alone. And the selection of ICDs in tension pneumothorax, usually you go with 24 to 28. So this is about tension pneumothorax. So we'll go to the next talk, the last one for the day. Okay, I just saw the chat box. How to decide about removal of ICD for pneumothorax? Now my next talk is on care of patients with thoracostomy tube drains. So it's nothing big, but I'll explain it in detail over that. I hope it's okay. Is the slide visible?
Yes, sir, visible. Sir.
Okay. So we've come to the last PPT for the day. This is not a very common topic that we see. We decided to put this for the main reason that in theory, invariably, that 1 or 2 bounces usually turn up. Like example, last year, that is in October 2023 in paper 2, there was a random question on chest physiotherapy and physical rehabilitation. Though we routinely see it on a regular basis, we don't read about it in depth during the exams. So at that point of time, when you have just 15 minutes for writing your answer, you need to pick up points as fast as possible, which may be very difficult. So anticipating this as a bouncer, we thought that we'll put this question for your theory preparation. So care of patients with thoracostomy tube drains, I'll be covering it under 6 topics. One is introduction, the indications for thoracostomy tube insertion, chest drainage systems, management of thoracostomy tube drain systems, that is the post-placement care, complications and troubleshooting, and removal of thoracostomy tubes. One of the candidates had asked regarding this, that I'll be covering it here. So coming to the introduction, thoracostomy tube placement belongs to one among the most performed procedures after central line insertions, arterial line insertion, and endotracheal intubations. So they are used in life-saving scenarios like tension pneumothorax, for enhanced recovery like post-surgical patients, or for symptomatic relief like in malignancies. So despite many benefits of thoracostomy tube drainage, there is always a potential for significant morbidity and mortality. Hence, regular assessment and troubleshooting of complications is very crucial for ensuring improved outcomes. So important to say, if you have an ICD inside, it doesn't mean that the patient is safe. You need to really monitor the functioning of it. You need to see how much drains are coming out, any other issues that are there associated with the drains. Only if there is regular monitoring can you ensure that the outcome is going to be good. So with the thoracostomy tubes placed in hospitalized patients require daily assessment to determine the presence of air leak, provide ongoing adjustment of suction levels, and monitor for malfunction, which may include obstruction, malposition, or disconnection. So this is very important to know. Many of us routinely have patients with ICDs in situ. So we need to always look for these things. That's the presence of air leak. If patients on negative pressure suctioning, the level of suction that is being placed and how much of adjustment will be needed. And we need to assess for malfunctioning, that is in the form of obstruction, malposition, or disconnections. So coming to the indications, one is for removal of air collection in the pleural space, that is pneumothorax, that can be simple or tension. Or removal of fluid collection in the pleural space, that is like a hemothorax, a malignant pleural effusion if symptomatic, chylothorax, complicated parapneumonic effusion, or an empyema. And use as a delivery conduit to introduce medications or fluid into the pleural space. That is internal warming via installation of warm saline. Pleural desis with talc can be installed to promote scarring of visceral and parietal pleura, and hypothermic intrathoracic chemotherapy in cases of malignant pleural, mesotheliomas, and metastatic diseases. So in the exam, at least 2 points, 2 indications for each of the 3 conditions should be mentioned. So the chest drain system, we have the 1 bottle system, the 2 bottle system, and the 3 bottle system. So the best way to remember it, you have 3 bottles for 3 functions. One is for a water seal, one is for drainage, and one is for suction. So because during theory preparation, it is going to be very tough for remembering the bottles and all that. So the best way to remember it, as far as I could do, is to remember these 3 functionalities and you can apply it. So the first one is the water seal, second is the drainage, and the third is the suction. So the 1 bottle system predominantly has a water seal and a drainage system alone. That is both incorporated. Whereas in 2 bottle system, there is a one bottle specifically for water seal and drainage, and 1 bottle for suction control alone. Then in a 3 bottle system, there is 1 for drainage, 1 for water seal, and 1 for suction. So this is the most simplified way I could put for this. So this 3 bottle system has separate for drainage, water seal, and suction. 1 and 2 has 1 bottle for separately for water seal and drainage, and in 2 bottle there will be 1 separate for suction. So suction is like the odd man out. So management of thoracostomy tube drain system, that is the post placement care. So there are 5 important things that you need to know. One is the precautions that need to be taken during initial drainage, monitoring the patient, assessment of the TT drain, and chest physiotherapy and patient transport. So precaution during initial drainage, the amount of thoracostomy drainage should be assessed on a regular basis, actually hourly in the setting of trauma. So with a traumatic hemothorax in general, immediate drainage of 20 ml per kg or accumulation of more than 3 ml per kg per hour of blood is an indication for the thoracotomy to identify and manage thoracic vascular injury. So I'll just repeat it once more. Immediate drainage of 20 ml per kg or accumulation of more than 3 ml per kg per hour of blood. All right. In cases of massive pleural effusion, the fluid should be drained very slowly. Not more than 1 liter should be drained in the first go itself. After which the tube should be clamped for an hour and then drained at intervals of every 1 to 2 hours, about 300 ml at a time, with the tube clamped in between. The main reason why we need to do this is to prevent the risk of re-expansion pulmonary edema. There will be very rare circumstances where there will be a large effusion, and along with that there will be a large active air leak also. So in those scenarios, the tube cannot be clamped. But invariably during the practical exams, there will be few examiners who will want to ask questions similar to this. So in those scenarios, there is an answer. So to reduce the risk of re-expansion pulmonary edema, the drainage tube can be draped from the insertion site to a level above the patient's head and then back to the drainage system, which is ideally situated on the floor. So I hope you can understand what I just told. So the drainage tube can be draped from the insertion site to a level above the patient's head and then back into the drainage system, which is ideally situated on the floor. So this creates a fluid trap that allows air to safely escape, but allows slow drainage of the fluid. If the collection bottle gets filled with drained blood or fluid, it should be emptied after clamping the tube, and it is to be done in a completely sterile manner because infection control has to be very meticulously done. The drainage system must be remaining upright for the water seal chamber to function correctly, and the chest drain system must be lower than the chest to facilitate drainage and prevent backflow. So monitoring the patient, the vitals should always be looked into: heart rate, BP, saturation, respiratory rate, and GCS. Pain assessment is important in these patients because if it is a pigtail catheter, usually the pain is going to be less. But if they have an intercostal drain which is a large French catheter, it's going to be very painful. So it needs to be addressed because that itself can cause splinting, decrease the respiratory movements, and it can cause atelectasis and it can worsen gas exchange. So it needs to be taken seriously. And we need to assess the insertion site and the dressing, because if at all there is any kind of oozing or bleeding which is occurring from the insertion site, it needs to be taken seriously, because there can be times where the neurovascular bundle that is just below the intercostal, that's the intercostal bone is there, and the lower edge may be punctured during drainage, that's the insertion of the tube. So that time the neurovascular bundle can be injured and that can cause bleeding. So if it is not picked up, and that itself can increase morbidity and possible mortality. So in respect to the respiratory parameters, you need to have an inspection of bilateral chest movement and auscultate the chest to assess the intensity of the breath sounds. And chest X-ray needs to be taken to assess the exact position of the chest drain and to evaluate the status of the underlying chest expansion. This is very important for a pneumothorax. And assessment for the presence of subcutaneous emphysema, because there may be instances where the tube, usually there will be 2 to 3 holes at the tip of the intercostal drain cannula. So if at all all the holes are not adequately inside and one hole is outside, so there will be like let out of gases into the subcutaneous plane, and that can cause emphysema. So it needs to be always monitored. So assessment should be done at a minimum every 15 minutes for the first hour immediately following chest tube insertion. Any alteration in the patient's hemodynamic and respiratory mechanics should be monitored for appropriate management. So this is what I emphasized. Thing is, this is already an inserted ICD. There could have been a probable kinking or block, or the tube could have been clamped during transport. So there would have been an initial resolution of the pneumothorax, but because the tube was clamped, there was no adequate outlet of gases in the pleural cavity, which will lead to reaccumulation. So it's very important to look into these factors while you are managing a patient with a thoracostomy tube. Next is about the assessment of the TT drain. It is important to monitor for tidalling. Now, what is tidalling is when the fluid along the dependent portion of the tubing is seen to move back and forth when the respiration is a sign that the chest tube is patent. So the absence of tidalling indicates that there is a possible tube occlusion and needs to be addressed. So the next thing is to assess for the integrity of the drainage system. You need to assess the amount and character of the drainage. Check if the tube is kinked or bent. Assess the water levels in the water seal chamber. And make sure the chest tubes are not clamped. The main thing about checking the water levels in the water seal chamber is if it is inadequate, excessive suction pressure can occur on delicate flora. That is especially if a negative pressure suctioning is being done. So it always needs to be kept in mind. And the water seal chamber level should be at least 4 to 5 centimeters. The next thing is to assess for air leaks. The presence of air leaks should be assessed to determine whether the tube can be removed. Most intrathoracic air leaks will usually seal spontaneously, and the resolution can be tracked by witnessing decreasing in bubbling in the device over days. So bubbling within the chamber can also be related to an air leak anywhere within the circuit. So the important thing is if you find that there is bubbling in the drain, you need to assess whether there is a issue that is extrathoracic or intrathoracic. So begin evaluation at the chest tube insertion site to evaluate if there is an atmospheric air tracking into the thoracic space via the chest tube insertion site. Then clamp the tube near the patient end and to assess if the leak is downstream. So if it is present, then you need to replace the unit and then assess for intrathoracic pathologies. So qualitatively, air leaks can be classified as follows with increasing severity. That is, only with forced expiration is a mild form, whereas if it is continuously occurring, then it is a true bronchopleural fistula. That is continuous, meaning it occurs continuously during inspiratory phase and the expiratory phase. So the level of suction that needs to be done is the initial level of suction used in the clinical setting is between -10 to -30 centimeters of water. When the thoracostomy tube or catheter is placed for fluid drainage, -20 centimeters of water is a reasonable place to start, and the level of the suction should be increased as indicated with the goal of achieving full lung expansion as determined by the chest radiograph. So this point is very important. So our ultimate goal with use of negative pressure suction is to assess for the chest expansion. For a collapsed lung due to pneumothorax or copious fluid pleural effusions, large differential pressure gradients should be avoided during lung re-expansion to prevent re-expansion pulmonary edema. If suction is not ordered, ensure that the suction port is left to open. This is also very important. This at many times may be missed because the staffs may not look into it. So next is about chest physiotherapy. Patients should be encouraged to ambulate as soon as possible. Deep breathing and breath holding exercises should be initiated as soon as possible after chest tube insertion. And this facilitates effective lung expansion and drainage of fluid. So regarding to patient transport, during transport, the chest tube bottle or bag should be always kept below the chest level. It is important not to clamp the chest tube as continuous drainage is the safest approach. In cases where there is an leak from the lung surface, clamping the tube will lead to accumulation of air in the pleural cavity, causing lung collapse and sometimes leading to risk of developing tension pneumothorax. So this was one of the case scenarios I discussed with the chest X-ray. So this is the issue that can occur because of that. So coming to the complications, you have organ-specific complications. There can be esophageal injury because the trocar is pushed too much inside. Or there can be gastric injury, especially with the left-sided ICD insertion. If the insertion is made too low, there can be bowel injury due to the same reason. Hepatic injury, especially with the right side ICD insertions. Splenic with the left side, diaphragm on either sides. Lung injury can be there if the trocar is forcefully pushed inside, which can cause perforation, infarction of bronchopleural fistulas. There can be cardiac or vascular injuries, especially when trocars are being used and first timers without adequate experience are performing an ICD insertion. They may push the trocar too much inside, leading to cardiac or vascular injuries. Or there can be intercostal arterial hemorrhage. As I told, during monitoring, we need to assess the site for soakage. So if there is a lot of bleeding occur, and we can have to suspect an intercostal arterial bleed. And there can also be chylothorax, especially with left side insertions. Then technical complications, there can be non-functional tube because of presence of kink, clot, or a dysfunctional closed system. Subcutaneous placement, tube dislodgement or removal. And physiological complications like re-expansion pulmonary edema or vagus nerve irritation, which is very, very rare. And infectious complications like site infections. The most severe form is necrotizing fasciitis and presence of empyema. So coming to the important part, that is removal of the thoracostomy tubes. It should be done to minimize as early as possible to minimize the risk of infectious complications. So in pneumothorax, the criteria we take for removal is we have to assess if the lung is fully expanded, there is no visible air leak present, and air does not accumulate when the suction is removed. If patient is on mechanical ventilation, it is ideal to remove the thoracostomy tube once the patient is on pressure support mode of ventilation, preferably. Whereas with pleural effusion, the decision for removal is made when the lung is adequately expanded, the drain output is less than 100 ml per day, there is no fresh or altered blood or pus draining from the chest tube. So for pneumo and pleural effusion, if these criteria are satisfied, then you can proceed for removal. So the removal technique is before removing the chest tube, the nurse assistant should be ready with the following setup. That is the dressing set with sterile gauze pieces and artery forceps. Sterile water impermeable dressing or tight dressing should be kept ready. At the peak of deep inspiration, the chest tube should be pulled out gently. So while one person removes the tube, the other person should be ready to tighten the purse string sutures that have been placed initially to prevent any air entering the chest, especially with post-surgical drains. So then a water impermeable occlusive dressing is applied at the site of insertion, which is then removed after 48 hours. Then post removal, it is important to assess for respiratory distress, and a chest X-ray needs to be taken for looking for pneumothorax or any other abnormalities. So these were the references. I think these will be, I've taken most of these and I've made it as PDFs for your references. Thank you. I think hopefully I've covered all the queries that few of the candidates had. So if any other queries are there, I'll be happy to answer them. Otherwise, I think it is over and we have successfully finished it before 9:15. So if anyone has any kind of doubts, you can share it on WhatsApp. We will answer it in that. So shall we finish it then? Okay. Thank you. Good night to all.
Thank you, sir.